to. You may notice that I'm not actually Dan Field. Our exalted chairman is not able to attend this meeting, so I'm going to be running things in his stead. I'm Jesse O'Brien with Augsburg, as I think you all know. I'm the vice chair of the committee, and let's just go around and do a quick round of introductions in the room and then on the phone in case there's anyone else. And we're a small group here in the room, so I think we can do everyone, not just the folks at the table. But
I'm Pat Allen. I'm the director of DCBS, and I'll take the floor for a second to not exactly introduce Chicky Flowers, but reintroduce Chicky Flowers to you as the acting administrator for the marketplace, stepping in to fill Barry's shoes. She's going to be acting through the end of session, and then we'll do a process to pick a longer term administrator. So welcome, Chicky.
Oh. I'm Shannon Saldivar from Revocoy Insurance.
I'm Sean Mathleby with Project Texas Map.
Cindy Condon, just a consumer health plan enrollee.
Shauna Butler, Tomlin Benefit Planning, broker.
Jim Hauser, Hawthorne Auto Clinic in Southeast Portland.
Chicky Flowers, Marketplace.
Claire Trenques with the Oregon Primary Care Association.
Elizabeth Cronin, Marketplace Communications and Legislative Manager.
And let's just go around the other folks in the room, starting with Victor.
I'm Victor Garcia, Operations Support with the Marketplace. Hi, I'm Ron Chum. I'm the CEO for the Community Health Centers of Lane County.
Susan Garcia, I work with the Community Health Centers of Lane County.
Chris Boone is Boone Insurance Associate, my broker.
Terry Moody, Boone Insurance Associate Agent.
Tim Sweeney with the Oregon Health Authority, Office of Health Policy.
Katie Button, Plan Management in the Marketplace.
Michael Schott, Performance Improvement Advisor with the Oregon Marketplace. Anthony Barron, Carrier Liaison with Marketplace.
All right, so Maria, we know you're on the phone, and thanks for being with us, but is there anybody else on the phone? I'm going to take that as a no. So I guess, first of all, Pat, was there anything else you wanted to say about the transition that we're going through right now, or is introducing Chicky enough for now?
Evidently there is. Well, just I guess I'm just assuming everyone knows, but maybe not, a fairly quick development that Barry Leslie was tapped by the governor to be her deputy chief of staff, responsible for her policy advisors and agency issues and those sorts of things. And it was kind of a whirlwind process that resulted that it's a great opportunity for Barry, and we're sorry to see her go, but it's a great deal. We decided that trying to juggle doing our recruitment for the marketplace administrator while we were in session, and candidly while we were still in kind of a bit of flux of what the world's going to look like, was going to be a little bit too much to manage. So we're going to we'll defer that. I haven't decided for sure yet, but I suspect we may do something that looks like I guess what I'd call a long-term acting after session, just because we're not going to know any more in 3 months than we know now in terms of what the world is going to look like. But we'll kind of see what that looks like at the time. Regardless, it'll be a competitive process that we'll go through to do that selection. Anybody have any questions about that?
All right.
Now all I have.
Great. So we apparently received a comment from someone that it would be good to have the public comment opportunities at these meetings spread out over different parts of the meeting to facilitate more public comment. I don't know whether there's anybody here who is planning on giving public comment or anybody on the line, but I thought we could maybe split up the 30-minute public comment period and provide 15 minutes now if there was anybody who wanted to talk, and then 15 minutes again at the end. Is there anybody who has a burning desire to provide public comment at the beginning of the meeting? Anybody on the phone? All right, well, wanted to at least provide the opportunity. All right, so the first item on our agenda is hearing some presentation. Oh, sorry, first of all, we need to approve our meeting minutes. That's important. Hopefully everybody's had a chance to take a look at the minutes. I thought they were thorough and high quality as always. Does anybody have any suggested edits or concerns about the minutes?
I move we accept the minutes.
Great. Any objection? Minutes accepted. I don't think we need to do an actual vote. So yeah, now officially, first item on our agenda is presentations from our gracious hosts from Community Health Centers of Lane County and Boone Insurance. Feel free to come up to the table if you like, or talk from where you are.
I'll swing over to this,
chair.
Can I also give a brief intro? So these are my people.
your feet?
So I'm Claire Trencaise from the Oregon Primary Care Association, and we were looking for a place to host a meeting in Eugene, thinking it would be fun to do it at a partner organization, and so I got on the line and said, "Hey Ron, do you got a good room for us?" And he said, "Why, yes we do." So he booked this room for us, and then also agreed to come and share a little bit about the Community Health Centers of Lane County. We also have our the outreach and enrollment lead from Lane County with us, as well as the partners from Boone Insurance, because I wanted you to see sort of the whole spectrum of how it works. We do serve a lot of people on Medicaid, but we have people that kind of go off and on, so we have to have a really good kind of flow with agents, and so this is a nice demonstration, I think, of how that works. And with that, I will let Ron take it away.
Thanks, Claire. We're delighted to host you today in our newest clinic. And for those of you who have been to Autzen Stadium, anybody here not been to Autzen Stadium? Okay, a couple Beaver fans.
I don't get into all that.
So the visualization that we use with our team is, imagine Autzen Stadium filled to capacity. That is the number of people in Lane County who have insurance today who did not have insurance prior to the Affordable Care Act. All right, about 55,000 screaming, excited fans, all carrying insurance cards, and very few of them having access to primary care. We had what we called a crisis of access in Lane County with all of these individuals, many as a result of the good work that you have done to provide them with insurance, but not having access. And so working with Trillium Health Plans, our coordinated care organization here in the community, Trillium put together a multi-pronged plan to expand access. And quite frankly, there was no way that the primary care marketplace of private practices could take on all 55,000 of those fans. Because you just can't absorb that many Medicaid and private insurance members, and of course most of them are Medicaid. As a federally qualified health center, that is uniquely one of our primary markets, is to provide care to the uninsured and the underinsured and Medicaid. About 70% of the patients who we see today have Medicaid. And so we worked with Trillium, and in the space of 14 months, opened 2 new clinics. Our Brookside Clinic on the west side of town, and that was not enough. Still needed additional capacity, and so we opened this clinic a little over a year ago, about a year and a half ago now. This used to be Parties to Go, and so there was a sense that we should maintain that name, Parties to Go Health Clinic. We decided not to do that but you know, if you ask nicely, maybe you'll get a balloon or.
You get the helium tank, right?
Yeah, we've got a great barbecue in the back. So we have done a lot to expand access, and I will tell you there was a little bit of a worry on my part as we were looking for space. One of the spaces we looked at, actually 2 of the spaces we looked at, were old Blockbuster facilities, and I thought, oh my God, am I building the next Blockbuster? It's got to change to telemedicine or whatever. And of course, the challenge is, you know, if you build it, they will come. Well, you know, the patients will come. Are we going to be able to get providers? And that, of course, is always a big challenge. I'm really pleased to say that we've recruited 11 new primary care providers into this community from across the country. So, you know, our message really resonates with providers who want to provide care to the uninsured and the underinsured population. And we're continuing to recruit. So if any of you know providers elsewhere in the country that want to move to the Willamette Valley, we'd love to have them. So this is our newest clinic, and we're really excited, particularly about this space. The clinic itself was a little larger than we had needed, but what it provided was the opportunity to make this space. You can see we have a residential kitchen set up here so that we can do nutrition education cooking classes and other sorts of community activities. So we do education, and that's a really important part of the health and providing health, not just what happens in the exam room, but the health of the individual. So we have done a lot of outreach. I should have Susan, you know, she's on the front lines of our team doing outreach and education, signing people up with insurance, which is really important. And we couldn't be happier, I'm sure you're there as well, that we have not had a significant dislocation in Obamacare and the insurance exchanges. A week ago, almost to the minute, I was sitting in Representative Fazio's office in Washington, and with the National Association of Community Health Centers, and we had over 3,000 people on the Capitol from across the country meeting with our senators and representatives, really saying how important the maintenance of the insurance marketplace and Medicaid and the expansion is to the health of the population. And obviously our message was heard. Fortunately, by that time, they had not done the vote. I joked with staff. I said, I'm going out to Washington. I'm going to fix health care. And evidently, correlation is not causation. But so we're delighted that we are continuing under the current expansion. So welcome.
Yeah.
Thanks, Bean. Quick question.
Yes.
What communication have you had with Representative Craig Walton?
Great question. We have had a lot of communication with President. Well, you can jump in as well, Claire. You know, he is in, quite frankly, he's in a difficult position. He's in a very conservative district.
In a very powerful position.
And a very powerful position. He is supportive of community health centers. He's in a position where he can't necessarily raise his hand and identify that support publicly, and we're doing what we can. He's not in our district, so I have less day-to-day contact with him. DeFazio is a huge supporter, as are both of our senators. Claire, if you want.
Yeah, I mean, I think when our folks were out in D.C., they met with his staffers, but they didn't end up getting to meet directly with Walton. So he is familiar with, we do have some pretty big health centers out in Medford and all across his district, so he is very familiar and has always been a supporter of, but yeah, it's hard to, I think he's maybe just not having some of those conversations with people that feel very strongly about the ACA expansion.
Well, I guess I might. When Lynn Saxon and I were back in D.C. 6 weeks or 8 weeks ago, we did meet with him for about an hour, and I guess I would give him a due amount of credit. The American Health Care Act was a bad bill that took a lot of, took the existing problems that there are and made many of them worse, but it did actually have some sense of being a legitimate effort at trying to replace an existing system with a different system, which is different than a lot of the rhetoric that's been going on in DC, which is, well, we'll keep these three things and get rid of those things, and without really any kind of discussion about how those things hang together. And so you talk about it being in a difficult position. It's an extraordinarily difficult position because he heads a committee that he had to fight to get on and jump the line to be the chair of. He's got a healthcare subcommittee co-chair or a subcommittee chair who is even more conservative and has a very different view of the world. And so he's got kind of a fine line to try to walk, and I think he's trying to walk it. It's just the running room that he's got to try to do things is extraordinarily narrow.
And as we know, healthcare is easy.
Who knew it was so complicated?
It really is.
I'm Susan Garcia. I am Oregon Health Plan Outreach Coordinator, the lead with the community health centers. We have different titles with different groups. We're outreach enrollment workers, community partners, and we're also certified with the sisters. There's lots of names. We're certified application counselors through the marketplace. So we have 4 sisters through 3 of our clinics, and we assist with Oregon Health Plan as well as marketplace plans. So we're all certified, and we've been doing application assistance with Oregon Health Plan since 2004. We have a lot of connections within the community with like Head Start, the school districts, so people know to refer people to us for help with insurance. I work at the Charlton Clinic, which is in our Health and Human Services building, which is houses a lot of different departments. So I get a lot of referrals from WIC and public health. I think them having someone to refer people to that they know is really helpful for them to, when a parent comes in and says, I don't know anything about the status of my child's insurance, they say, I know who can help, So it's, we're getting, a lot of people are getting to know us about the assistance that we do through word of mouth, and other organizations have had good, they refer but we also attend the events. We do library events, the Dia de los Niños, Dia de los Libros events at libraries, as well as there's a family festival.
Sorry. And if you're not talking, can you mute your phone, please? We're getting some noise.
So we're in the community. We have tables. We let people know about our primary care services as well as the assistance that we give with Oregon Health Plan. We, as application assisters for the marketplace, we're in a unique situation because we can't tell people our opinions about plans. We're not insurance agents. So we do try to refer people to insurance agents as much as possible. Some people, as they've gone through past applications for Oregon Health Plan and were, found over income, just want to be with us because they know us. But we really do try to encourage people to meet with a specialist who can give their opinion about the plan, because we're kind of limited with that. And through a lot of our referrals to them come from our patients who have turned from insurance, no longer eligible for Oregon Health Plan due to income, and it's really nice for them to know that they do have options if they're in the special enrollment period, and that there are people who can help them for free. That's, and they don't need to know everything about insurance, because there's people who can help them. And just knowing that takes like a huge weight off of people, just to know that there's somebody on their team who are watching out for them, because it's not easy. So we're also in a unique position because people come to us referred through Oregon Health Plan for insurance assistance, Oregon Health Plan insurance, and they say, oh, you guys are a clinic. We had no idea you existed. And so I have a unique position also, because I can offer them a visit with a doctor, which is something that not everybody thinks that they're going to get. Like, I have insurance now, what do I do? So having that in with the clinic, I can set you up an appointment right now, is really beneficial for them. So they get insurance and a doctor in one visit, so it's great. We we refer to insurance agents, and we give them a list of the insurance agents that do offer free assistance to the community. Ever since the ACA came into effect, Chris Boone with Boone Insurance contacted us and said, we'd like to partner with you. You know, we can identify people who qualify for Oregon Health Plan, refer them to you, and you can always give us their information as well. So although we don't promote or say this is a good insurance agent to go to, we can give them that we've worked a lot with them in the past and had really good experiences with them. So I asked Chris with Chris Boone Insurance agents to come and talk a little bit about our relationship with the Community Health Center and a private health insurance.
Yeah, thank you. Thank you for the invitation, and Susan, thank you. So we took on ACA in 2014, along with a lot of other agents in the community, and unfortunately we've seen some agents have to remove themselves from that marketplace based on that. Changes that have occurred. We felt early on that in order to be successful in this marketplace, to be able to serve consumers effectively, we need to create partnerships with community partners. And so early on, we reached out to the list of community partners and grantees in our community and tried to create bridges where we could communicate together to help serve consumers. And I think Community Health Centers Lane County has done an amazing job at that. I think Susan spoke to this briefly, but the ability for them to help consumers get into the system, not only get coverage, but then plug in potentially, is a huge advantage that they have been able to provide. It's worked really well for us. We've talked at the state level as, for those of you who might not be aware, OAHU or the Association of Agents, about trying to maybe get additional Medicaid training for the agent community. That's been a difficult proposition for a variety of reasons, but community health centers and other partners have really helped facilitate that knowledge base for consumers and getting them plugged in. So I think agents in most communities should be taking advantage of these partnerships and helping leverage them for both their organization and the other one to help these consumers, because it is a really complex environment and you do get a lot of churn right at those cross marks for the FPL tables. So it's been really great for us and our team to be able to use and have community health centers as a partner for us. They've been great in working with consumers, so I just wanted to share that. And I think as we go forward through whatever this transition is, again, who knows how long and when, right? But I think change will occur, and through that change, I think it's going to be even more important for, I think, community partners and the broker community to come together, because we each play a specific role in this, and sometimes the consumer doesn't know exactly what that role is, but if we can work together, then it works good for them. So thank you.
Question. Susan, what is your lead time? Does it take 2 weeks to get an appointment? Is it 2 days? The community partners that I'm working with are just booked up.
We just added another sister in February, so we have appointments within a week. Before it was 2 or 3 weeks out.
Oh, yeah.
It was difficult to get people in, and then we're doing good right now.
I have a question about that lead time. So does the let's say then they become eligible for OHP, does their coverage go back to that first date of that they requested an appointment, or the application date?
It's the date of request. Right now, Oregon Health Plan does retro back to the first of the month, and then there's an option if you have unpaid medical bills in the last 90 days of marking those months. So it could retro back, but the date that they contact us is the date of request.
Oh, okay. Well, that's good. So that even if, I mean, I know it's always good to be able to get the application in right away, but to know that the day they made the call is
they contacted us for assistance as their date of request, and that's usually recorded on their appointment.
I have a couple of questions for Chris specifically. When you said that some agents and brokers have had to pull out of this marketplace, can you kind of flesh out why that is a little bit more? I have some ideas of why it might be.
So more and more, let's reference mostly health insurance brokers, right? Our renewal dates have lined up around January 1st. And like we've been speaking, our agency, we do employers 50 and under, we do Medicare, and we do individual. we work with probably 90% of new revenue and retention of revenue in 1 quarter. We have already tried to design Flex for teams. We also have to figure out how to work with those consumers and provide good value. There's also this compensation component to it. And so we, just like any business, have to decide what markets we want to play in and what markets we don't want to play in based on market circumstances. The challenge at the individual market, not so much in Oregon, thankfully at this point, is we're still getting commission on the majority of our products, but there's some that are starting to have that discussion. And the time it takes, I think certain brokers have aligned around different product lines that are easier to do, less cumbersome, and actually are more stable. So what we found, and we watch our numbers for what business we put on the books, there's a lot of people, if you look at marketplace numbers, they go on, they either never pay or they come off. And so you have that front load admin cost, but you have no revenue to support that. That's a challenge for a private industry. And so we've seen a lot of bigger brokers in our community that have come to us and said, hey, we're not going to do this. We still want to facilitate helping people. Can we partner with you and send those people to you? Great. So there's certain brokers in each community that are still committed to it, but every agency is taking their own approach to it based on that. Does that help answer?
Yeah, absolutely.
And I'd like to add to that, please, Jesse, just to play off of what Chris said. The time that it takes to work with the marketplace individual, especially when there are any problems, is just inordinate. It's much longer than any other line that we work with. So it really does take a lot of our time.
I just got an appeal back from a case that I submitted last April, so they would now be getting onto coverage as of roughly May or so of this year, more than a year after their initial request. So that's sometimes what it takes.
That's not uncommon.
And I will state this one thing, and again, I know there was a significant amount of challenges upon the launch of the AT and how Oregon approached being a state-based exchange versus federal exchange. But local control versus federal control has been really nice for Oregonians. When we did have some of that, even there was complexity, we could resolve issues. Leading it to the marketplace is very difficult, as people know, to get answers and to help resolve issues for consumers. That's been a challenge.
And then one other, I don't know if this is even a question exactly, but I'm sure, Chris, that you're aware that the DCBS Division of Financial Regulation recently released a bulletin on agent and broker commissions, and I'm wondering, one of the issues that outlined was something we've heard popping up around the country of agents getting either no commission for marketplace plans or reduced commission or no commissions for a special enrollment period enrollments. Had you been experiencing any of that prior to the bulletin?
Yeah, there was a carrier in Oregon that removed themselves from paying commissions in 2017. We've also seen carriers reducing commissions after they've done their rate filings. And so I think it's a really tough situation for DFR. And I think that it seems like the bulletin, I think from the broker community, helped give clarification, but the relationship is factual between us and the carrier, right? And it's a tough situation to have the state get involved in that component of it. But I think there's this component of if you're going to file rates and you're going to base sound data on that, you shouldn't be changing other factors once those rates have been filed. And I think the bulletin kind of addresses that component, but it still allows for them to have their independent kind of relationship with the broker. But we are seeing that. I just actually yesterday for this I get this national, it's our association thing, and there's like Tennessee and some other states, they're just not paying brokers commission at all. And there's a real concern in certain states that agents are going to leave the marketplaces altogether, not help consumers. They're only going to work in the direct market. And so like I said, I think Oregon, that maybe helps solidify part of that as we come into the rate filing for 18. But again, and I can't emphasize this enough, and I think if you talk to brokers, you'll find, and you're lucky to have brokers on your committee, but people who work in Medicare, for us, with all the boomers out there, and we're heavy in Medicare and small employers, it's a way better revenue stream for us to spend the time and energy there in terms of retention of book of business than in the marketplace. So we want to be in this market. We want to help consumers. We think it's the right thing to do to help them navigate the complexity that's here. But we got to have the ability to do so with everything else that we have on our plates.
Well said.
All right. Well, we should probably move on unless anybody has any burning questions.
Yeah.
Thank you.
I'm glad to have you.
Thanks so much for coming by and for hosting us here. So do we have Stephanie Kennan on the line?
I am on the line, yes.
Fantastic. So we heard from you at our last meeting, but I'm sure that people are very curious about what's going on at federal level right now, and what's I imagine that, like me, a lot of us have been glued to the news and trying to sift through some fairly confusing tea leaves. So go ahead and give us all of the insight that you can provide.
Okay. And I apologize, I am in New York. I thought I would be back in DC well before this call, but the weather's bad. So I'm in the quietest place I could find, and it isn't always quiet. Let me take 2 steps backwards and talk about where we were as of yesterday. We are in a different place today. As you remember, the bill was pulled an hour before the vote, and everybody declared healthcare reform dead. And the impetus and the reason everybody was rushing was because of the budget reconciliation rules. The reconciliation rules allow you to get this through the Senate without a 60-vote majority. The rules expire on April 28th because the budget resolution expires on April 28th. There have been a variety of talks between the conservatives, the Freedom Caucus, and the Tuesday Morning Group, which are moderates, and the White House. And then the moderates and the conservatives have talked amongst themselves. The only chairman that I'm aware of that has been in any of those discussions was Chairman Walden. And that's probably in large part because Medicaid and insurance go through his committee. Ways and Means really just has the tax portion. Nothing came of those conversations. And then the White House tried to meet with the Blue Dog Democrats. It was a cordial meeting. They didn't get anywhere. They both promised to come back and talk to each other. There were conversations again on Tuesday night, and things went really, really bad on Tuesday night. So on Wednesday, I told Pat Allen that healthcare reform was dead for the week. It's not. Apparently the leadership, which had not been in any of these conversations, met with the White House last night, and there was a unhappy conversation. However, Reince Priebus apparently convinced Paul Ryan that they had to do something before they went home to show that there was some progress. Several things were discussed last night. One of the things that was discussed apparently is not coming to fruition, and I'm just going to mention it, and I don't have all the details, but it was to try to align some of this along the lines of what Maine does in its Medicaid program, and I don't know enough about Maine's Medicaid program to be able to be articulate on it, but that went nowhere. The one thing that they were able to agree on is a $15 billion with a B risk-sharing program, and in its name, it is called the Invisible Risk-Sharing Program, to help states reduce premiums by reimbursing insurers for high-cost individuals, and that would begin in 2018. They went to, I'm sorry?
That $15 billion a 10-year number?
Yes. So they went to rules at 12:30 this afternoon to add that to the existing legislation that was pulled off the floor. As far as I know, from talking to some folks, this was anticipated that there'll be a lot of debate, but then they'll just do it. That does not mean they're bringing it to the floor today. It doesn't mean anything other than it gives them something to go home and say to their constituents, look, we heard you about high-risk individuals and high-cost individuals, and so we're going to be adding something to our bill to that. They were really afraid of going home and getting beaten up because of how bad the bill was. in the public's view and not having made any progress. So that is where we are. Congress is going on recess starting on Friday. They will be gone for 2 weeks. Some staff has been told to try to work out some more details on some other issues. But I'm going to try to describe this gently. There's not a good relationship right now between the White House and the Republicans in the House. No senator has been involved in this particular last round of conversations. The only senator that's been involved in any conversation was Rand Paul, who cannot speak for the Senate. And it's unclear that the White House has a Senate strategy yet for any of this. So my guesstimation is that some staff will get together and they may talk about some things, but when they come back, they have to focus on funding the government past April 28th. They want to get something done on health care because it would make tax reform easier. They could do another budget reconciliation proposal that would go from April 28th to September 30th and use reconciliation instructions again for health care reform, but they had really wanted to use that for tax reform. So why don't I stop there and take your questions?
Stephanie, it's Pat. Just to be clear then, this invisible reinsurance or whatever they're calling it, since it's not, it didn't get added to a bill because they haven't done any kind of further markup or amendments or anything like that, and they've not moved anything. So the progress they've made is they've added a bullet to their talking points?
No, they are adding it as an amendment to the American Health Care Act, the bill that was pulled. Rules Committee can do that. Rules Committee can rewrite a bill in that committee.
But they haven't done it yet, right?
Well, they're in the process of doing it as we speak.
Oh, okay. Okay, got it.
So to go back to
they went in at 12:20. I don't think they're done yet.
Okay.
Cindy Condon. So I think you had said that the administration met with Dr. Patch. Do you have a feel for Schrader's, Representative Schrader or Congressman Schrader, where he is?
He's been very supportive of the state. I don't know where he is on this particular amendment. I don't think a lot of members have actually had time to really look at it. He was in the Democratic camp of voting no on the AHCA. There wasn't a single Democrat that was going to stray.
Yeah, when we met with him a couple of months ago, he was, as Stephanie says, very supportive of our position, very well informed about, it was conversant in the challenges with the AHCA. And I also happen to know that he reached out yesterday to at least one insurance CEO, like right contemporaneous with this. So I suspect what he's trying to do is gauge the impact of different ideas on insurance.
Thank you.
Stephanie, this is Chicky. So you mentioned for this invisible program, insurance risk sharing, you said $15 billion over 10 years. Do you have a sense of how they plan to distribute that among states?
I do not right now. I will have a better idea probably later this afternoon. I've only had a chance to look at the text of the amendments briefly, and it didn't have how it would be divided up, but I'm not sure I was looking at the actual text that's in front of the Rules Committee, and Rules Committee can add things. So I will have a better idea later this afternoon.
Thank you.
Will there be another CBO score on this with the new amendment?
There would have to be.
Well,
they went to the floor without a CBO score, and I don't know the CBO has ever finished scoring that bill, but they'll have to add this to it. It's also unclear how they're paying for that $15 billion, by the way.
Well, by cutting Medicaid, I think.
Well, that's where the money is.
So I'm not sure exactly where to take this conversation because there's so many questions to ask and there's so little actual information that's reliable. But one of the questions I had, I don't know whether you have any insight into this, Stephanie, is what approach the White House and I guess it would be specifically the House is taking toward the House v. Burwell court case.
Sure. It's now House v. Price. Paul Ryan has said that he wants to go ahead with the suit because of the issues related to separation of powers. We're not really sure where the White House is on continuing the suit, and we won't know probably until the next date they have to file something, and that's May, I want to say May 20th, but it's in May.
So after Oregon insurers have filed rates, for example?
Well, the one thing that is good, though, is that Secretary Price has signaled to people that have met with the HHS on the CSR payments that as long as the suit is out there, they're inclined to support making those payments. That isn't a definite yes, but it's a better than a no.
There's some other questions I could ask, but does anybody else have any questions?
I feel like I depressed you all.
You should be used to that by now.
Jesse, may I offer, even though there may not be questions right now, please feel free to email me with any questions that you might have driving home or even that's keeping you up at night, and we'll follow up at a later time, especially since this is it's still developing as of now. So happy to take your questions and follow up at a later time.
I do still have one question, which is, I know that one of the things that's been discussed in the negotiations between the White House and the Freedom Caucus is the idea of taking out the essential health benefits or issue. Has that matured to the point where there's a chance that that would actually be put into legislative language, be part of the amendment to the $15 billion number?
That's a good question. The last round and consensus on that topic was that you would allow states to opt out of community rating rules, essential health benefits. Could be both, could be, whatever the regulations are, they could opt out. And so the regulations would continue on the books. The conservatives liked that. The moderates did not. The moderates were very concerned about allowing states to opt out of community rating and what effect it would have on older people in particular. There's also, the moderates aren't so wed to the essential health benefits, but there was some concern over what if a state wanted to drop some and not all, and would you end up with a hodgepodge? And they just couldn't figure out what that would look like, because one of the things the moderates do get is that the essential health benefits and the way things are divided by the metal plans makes it a little easier for people to understand what they're getting, to the degree that people actually read what they're getting. So that was one of the sticking points between the moderates and the conservatives. I think there would be some moderates who might go for some opting out, but right now they aren't speaking the same language, I guess is the best way to put it. But I don't think that idea is going to go away. Rand Paul has been pushing it pretty hard. And in fact, if you track back the events, Rand Paul played golf with Trump. He mentioned the opt-out stuff, then it suddenly pops up in conversations between the White House and the Hill. And it would be a compromise, not a great compromise for some, but a compromise.
I mean, I suppose if it was just an opt-out, then it wouldn't necessarily have to affect what we do in Oregon. But
Right.
It's also worth noting that Milliman did a good piece on analyzing which elements of the essential health benefits are cost drivers. Everyone talks about like labor and delivery and why does a 60-year-old guy need labor and delivery? And it's a really small piece of the cost driven by EHB. What really drives something like well over 50%, might be as much as a third, are hospital coverage, prescription drugs, and seeing the doctor. So if you want to save any money, you basically need to cut out everything that makes it insurance.
Well, I've also seen some other that indicate that even among all the cost drivers of the different provisions, that what they call the Title I protections, which are the community rating, the guaranteed issues, that's an even larger portion of rate increases and costs than EHBs altogether.
Right. Yeah.
I have a question. This is Jim Hauser. Has anyone talked about whether all of this really can fit under what they call reconciliation? I mean, I thought reconciliation was narrow, and they're like rewriting the whole bill without the essence of it.
That's another good question. When they were discussing the opt-out portion, the one concern by the Freedom Caucus was that they were afraid the Senate parliamentarian would drop it out of saying it didn't apply because of the Berg rule. The Berg rule requires that you affect federal spending one way or the other, and those provisions would not. That would have been a continued sticking point, except for the fact that their discussions fell apart. And again, reconciliation basically expires on April 28th. So if they don't do something using reconciliation by April 28th, which it doesn't look like they'll be able to, then they either have to do another budget resolution with reconciliation instructions, or it's the old-fashioned way and they're going to need 60 votes in the Senate. The one other thing I wanted to mention that I've neglected to mention at the top of this is that they did pass the Association Health Plan bill that they were going to carry on with reconciliation because reconciliation itself couldn't have it, but they wanted to show that they were for Association Health Plans. That bill has passed the House before. It's always died in the Senate, and it doesn't make sense for the Senate to take it up on its own without an ACA repeal or replace. But it's out there, and there were two other bills that also came out of the Ed and Workforce Committee. They weren't on the House floor, but they might reappear. One has to do with employer insurance and variable premiums if you participate in healthy activities. And the other, and I'm blanking out on what the other one was. In any case, those bills will reappear if there is a repeal and replace that's not on reconciliation. You can see that's being packaged up as part of a larger health care package.
So just to clarify, you were saying you think that the Association Health Plan bill won't move forward on its own? They want to wait until they have a more comprehensive package?
Yes.
Okay, interesting. Cindy, do you have a question?
Well, and maybe more a comment, but I've been struck by the conversation at the federal level, that there's a conversation about the increased number of people covered, and that's a great thing. But the administration conversation is pointing out people who likely pay for their own health insurance and their premiums are going up. So kind of coming from very different places. And I'm just wondering, it sounds like crosstalk to me, and where it became very apparent is on some news program, they were interviewing a ranching couple who were absolutely supportive of the ACHA, and they were talking about their daughter who was very physically and mentally challenged who received Medicaid benefits that were great, but their premiums had increased significantly. And it was their premium increase, significant premium increase, that was driving their opposition. So I'm wondering, how does that play out in the conversation in Washington, talking about really quite different parties? People that pay for their own health care or health insurance and health care versus publicly provided, and the cost involved in that.
I think you're correct that there's a lot of crosstalk and things not connecting. I mean, I'll be blunt. A lot of the people who are leading these conversations, and both from the White House and from the Congress, don't fully comprehend everything they're saying or believe. As someone said recently, who knew it was so complicated? It's complicated. They may know a piece of it, but they don't know the whole, how everything fits together. And that's making the conversations more difficult. The conservative caucus is a different breed of animal altogether. They don't want to negotiate. They want things their way. They came to Congress to change things, and they fully intend to change things their way. They also fundamentally believe that the government is in healthcare too much. So that's why they're okay with the peeling back the Medicaid expansion. And that drives their view of it. And you can agree with them or disagree with them, but that is where they're coming from. They want the government out of it. So that colors a lot of the conversations. The moderates are all over the place on different things, but it makes the conversation harder when people come to the table with a view of, I want the government out of it, and nothing you can say is going to make me get any government involvement in my support. Now, at one point, the Freedom Caucus thought that they would agree to something, and about 6 members wouldn't agree, and they realized they were not going to be a voting bloc anymore, and that may be where they end up ultimately. But that's coloring a lot of the conversation.
Okay, one more question that you may or may not have insight into, but and this is sort of pretty far off the radar of what's been in the news, but I think it's something that we're going to have to think about if it actually happens. Which is there's been some talk about significantly shortening the open enrollment period. Do you have any thoughts on what's going on with that and the likelihood that that will happen?
I do think that they want to significantly shorten the enrollment period. I wish I could give you a percentage of, I mean, I think it's likely to happen. I'm not sure exactly when it will happen. We know that HHS is in the process of going through every single regulation that touches the ACA, and that's not just HHS, it's Labor and Treasury as well. We know it'll take them over a year to do that. But they're making notes as they go along, and one of the things that people have said to them, and some of the insurers have said this, is that the enrollment period is too long, and you need to make it much more short. The other thing, too, is they think they've been...
Right, that's already close.
Yeah, so I was actually hoping that NPRM would be finalized by kind of this week, but we're not even hearing hoofbeats on when it might be finalized. But comments are closed on March 7th on that one.
They want to have it done by the end of April.
End of April, okay.
And it could very well pop. It could pop out next week for all we know.
And this is one of the areas where insurers believe two mutually exclusive things at the same time. And I'm noticing that there are actually several of these, and they really honestly do believe them both, or they understand that they believe conflicting things, but they still believe them both. One is they believe that this will harm the risk pool because those who are more likely to get in a shorter window are more likely to be sicker than those who sign up at the deadline. And they believe it's a big deal to not have people getting coverage that starts at a partial year. And so the December 15th end of open enrollment is important to them because that gets 1-1 coverage rather than 2-1 or 3-1. So.
And that same rule tightens up special enrollment rules, which I think has the same effect, that if you're sick, you have the motivation to get through that narrower door, and if you're well, you might say this is more of a hassle.
Yeah, they aren't of mixed minds on that. They very much believe the system is being massively scammed by millions of people who are signing up for coverage, getting their hip replaced, and then dropping their coverage.
Like motocross, right?
Yeah.
There's not, shall we say, a lot of evidence to support that.
Right. We are living in a post-evidence world.
This is Sean McNulty. There's a couple months back there was a draft executive order leaked about expanding the public charge rules for Medicaid and tax credits and other programs. Has there been any other movement on or indication of where those rules are heading?
I honestly don't know. I'm not sure they've really been a focus in the last couple of months. It's something I should go back and check on.
All right, so I guess I have one more question I would like to get out there, which is, to what extent does Oregon have any flexibility around some of these things? I mean, I know since we use healthcare.gov, we're subject to federal whims in a lot of respects, but is there any flexibility around some of these proposed rules that would tighten up enrollment processes and so forth?
Much. In the draft orders, in the rules that we commented on, there wasn't much.
We're really beholden to their system, and when it comes to like the information that we feed to them, they've been really flexible and have let us add plans later and expand and decrease service areas and things. When they told the regular FFM states they couldn't, but there are only so many things they can change, and there's very few of them. So really, anything that's consumer facing has to be on the thing.
Frustrating.
There's also a slight cut to tax credits in that rules change because they widened the band on whether a silver plan will go from 68% actuarial value to a minimum of 66, and that's going to be the second lowest silver plan that they're basing the cost off of light cut, and about $80 a year in tax credits for.
All right, well, that's all very clear as mud, but I think it's probably time to move on. Thanks so much, Stephanie.
Thank you. Bye-bye.
Thanks. All right, so speaking of clear as mud, time for updates from the Oregon legislature. But we should maybe take like 2 to 5 minutes to grab food and continue talking about this stuff while we eat. All right, we're going to get started back up here. So we're going to move on to the Oregon legislative update with Pat and Elizabeth.
Okay, where we dive in. A couple of things going on. I know that we circulated with you some time ago our market stability ideas, and you'll remember perhaps that the idea was we were kind of defining market instability as geographic access to carriers, affordable rates, and financial stability of the carriers themselves, and we've kind of been dialing into about, I don't know, 9 or 10 ideas that we thought had some merit to contribute to that stability. And the election happened, and we kind of put everything on hold. We're back to moving some of those ideas. We're becoming increasingly concerned about what the landscape will look like in the market for 2018. It's clear from the earlier conversation that we really don't know for sure what the federal environment's going to be like. It sort of mostly feels like we're going to be playing by ACA rules for 2018, but maybe ACA rules with the occasional hand grenade rolled into the tent from the administration. And so we're concerned that the rational reaction by carriers would be just that we're just going to step out of the market and wait and see what happens, which of course would be disastrous. And so we've been in some fairly intense conversations with carriers about what it would take for them to be in the market and for them to basically not price with a huge risk of the unknown premium. And we've got some things that we're getting close to being able to roll into the legislature to do that. The one that's readiest, because it's now been reduced to bill language, and I think we'll get it substituted into a bill here shortly, is what I'm calling the DCBS Do Whatever You Think Is Best bill. And what it looks like it will say is some version of, notwithstanding any other laws about anything, if one of a number of trigger events like changes in federal law that trigger an increase in that would have an impact on rates happens, we're able to set aside, waive, change, whatever, any kinds of requirements that we have. And the idea that we've talked through is that what we would do is use that as a way to be able to respond from a practical standpoint after about August 15th to changes that disturb the market and allow us to try to be relatively nimble. I think it has a 2-year sunset, so it's not permanent superpowers. I like to joke, as director of DCBS, I get some of the most boring superpowers. Yeah, important, but dull. Anyway, it would be like a 2-year window that we'd be able to do that. So that answers the question that came up earlier about sort of what happens if things change and that's not built in. I know I talked about before, but it's worth mentioning again. We have a lot of flexibility up until about August 15th, even though rate filings are due May 1st, and I'll come back to that issue in a second. After the rate filings come in, we've got some ability to adjust. We've got an appeal process that's built in. We used that last year to get carriers back into counties that they had withdrawn from, and yeah, that kind of thing. So we've got a fair amount of running room during that summer window. It's what happens if there are changes after that, or let alone during a plan year. So that concept is out there. We've also then been working on a select number of the ideas that we were kicking around last summer to move forward with. The most significant of those is reinsurance. Reinsurance gets wrapped up in the overall budget deal because part of the overall budget in the governor's budget is an insurer tax as well as a provider tax and CCOs and all those kinds of things. And so you can't do one without thinking about how it relates to the other, and we're in the midst of those kinds of conversations right now. And it's sort of how big does a reinsurance program need to be able to be meaningful, to make the carriers more comfortable, and we think we're getting close to that number. Also, Alaska got a 1332 waiver to do a fairly significant reinsurance program, and they figured out to make the argument that, if we do reinsurance and that drops rates, then the federal subsidies go down, and so you save money, so you should send us some of it. I wish I had thought of that. Yeah. So we're likely to want to file a similar waiver if we move forward on reinsurance. I'm a little worried that if the administration figures out all the blue states are doing this, because Minnesota has filed one and Colorado is getting ready to do it. If they figure out that's how this is working, their interest might change. But they've been sending out letters and making phone calls saying, hey, you guys want to do this? So they're really eager for us to file a waiver like that. Some of the other pieces that are in that concept include a couple of things around plan design and rate. And one of the things, I know we talked about this for a little bit, one of the things we learned last summer was actually wide variation hurts the stability of the market rather than helping it, which is a little bit counterintuitive. Nobody wanted to be, what everybody wanted to know going into coming back to counties last summer was, am I going to be the only one, and am I going to be $100 a month less than everybody else? Because that means I'll get all the risk, and I don't want all the risk. And so we're talking about ways to narrow the field. I think that's actually good for consumers in terms of plan design, because right now we're given 75 or 80 choices of plans, and it was something like 140 back when we had as many carriers as we had, and it's too much to be able to intelligently choose from. So, and we now know enough about this market to really, this is actually borrowing a concept from workers' comp, where we have one of the most successful systems in the country. We know now what the claims information looks like for this pool, and so you're much closer to being able to say there's a right answer of what your claims losses should be, and we think it's this. and you should file this unless you've got some persuasive argument about what makes you super different. And so I think that would be a piece of it. We're also looking at possibly incentives to maintain coverage, more likely the idea of basically some kind of a state version of an individual mandate. The challenge on that one is to make it meaningful enough to drive behavior. It probably has to be so big that it's politically impossible to do, right? So, I mean, the obvious penalty would be that the penalty is the equivalent of what you would have paid for insurance. And so you may as well get the insurance because you're going to be out the same amount of money, and why not have insurance instead? Well, I couldn't possibly get that out of the legislature. So if it ends up being a procedural, we won't process your tax refund until you show proof of insurance or something like that, will that really drive a lot of behavior? There's not a lot of evidence that the current mandate is driving a lot of behavior, so we're kind of working through that. There are a few other things that are deeply arcane, but those are kind of the signature features of that. So we're working on that. And then the third piece that we're continuing to work on is the whole notion of what happens if we end up with a county or other geography that has no carriers at all, and what are we able to stand up in its place. One of the things we're realizing is that will be almost impossible to do in time for January of 2018 if that happens. So we're really putting a lot of our eggs in the basket of getting carriers to commit that if we can do this package of stuff that they'll stay in the markets that they have now for 2018. Because we just think it's very unlikely we can be done by that quickly. Those are the main things in terms of markets.
And I have just an update about another bill that affects the marketplace, which is Senate Bill 147 that has passed the Senate and looks like it will pass in the House, and it has to do with COFA, COFA community and dental coverage. And it does not create a COFA dental premium assistance or cost sharing assistance program, but it calls for an advisory committee to be convened to study the concept and to report to the legislature about a recommendation. And so that Chicky and I attended the hearing on the bill, and there was a lot of support among the Senate Healthcare Committee, not just about the scope of the bill, which is to look into the concept, but even they started to, some of the senators even spoke to a program and voiced support for the actual establishment of such a program, which then, potentially would come after the convening of the committee and the recommendation. So that has not yet passed the House or been signed by the governor, but it looks like a pretty smooth road.
I think that's the main stuff we have going on.
As usual, I have a lot of questions. Does anybody else have questions first?
I have one. Massachusetts has an individual mandate. What was the process like? What is that? What are the requirements? What does it cost? How hard was it to get it passed? Is there a lot of resentment? Has that been a problem? Is there arguments to repeal that?
I don't know the details of that mandate, but remember, like a lot of features that Massachusetts has, they came from Romney Care, back when all these things were Republican ideas rather than Democratic ideas. And so the political dynamics are then would have been considerably different. Mm-hmm. So I don't. The bottom line is, what is the penalty for failing to meet the mandate? And I don't know the answer to that. We can look into that. In terms of process, though, kind of almost, I guess, regardless of what their process was like, I'm just really certain that anything that would be big enough here that would be a hammer that people would say, oh gosh, I better get insurance. I just know I couldn't get it out.
Because I understand they have like a 1% that are using, that 99% are enrolled, only 1% are using whatever that process is, that mandate process. I thought, well, it must be pretty functional, good.
It's a 50% of the least costly available insurance premium adjusted based on age.
Yeah.
Oh.
So it would be, let's say we're talking about a 55-year-old, it'd be a $6,000 penalty, give or take. Yeah, I couldn't get myself out of the building after proposing that little bill. All right, we'll dive into your questions.
So, one question. It makes sense to me that it would be at the very least extremely challenging to stand up a carrier of last resort concept in time for the next plan year, but you are still thinking about doing it, right? And it just wouldn't go into effect until 2019, right? And then, correct me if I am misremembering this, but I feel like during some previous conversation that I was involved with, we talked about having this committee be involved with the kind of DCBS can do whatever it wants, declare a state of emergency.
Yeah, and Lead Council came back without that that language. I think as a matter of course, we would still want to involve this committee just in terms of public process improvements and those kinds of things, even if it wasn't a required step. Yeah. I mean, honest to God, Lead Council came out with a 1.5-page bill, and I was shocked. I was expecting some massive, 800-page thing that went chapter and verse, and it just, no matter what any other law says, do what you think is best. So they went for simple, which is not very typical.
Yeah. Given all the turmoil at the federal level, is there conversation in the Oregon legislature for a public single-payer option for Oregon that could go some way?
Well, so two different halves to that question.
Yeah.
There is increasing talk about single payer. There is supportive comment coming from unlikely sources. Republicans have been saying, well, maybe we should just do single payer. How serious that is when, if it comes to actual votes, is maybe a little bit of a different question. I don't think they'll come out of this session with a single payer plan, for the simple reason that they've also got a $1.3 billion budget shortfall, and that really is sucking up all the bandwidth, and it involves potentially a big piece of it is the OHP shortfall, and so all the bandwidth on this kind of stuff I think is going to that, and so there's interest, but there's not enough space to be able to really get there. I think some conversations could well start and move down that path later. Also, I mean, if you look at what we're doing around standardizing the market, that's making it look a lot like Medicare Advantage. If you look at what we've talked about for the alternate carrier plan, moving them into CCS, that looks a little bit like, and so some of what we might manage to do is actually do some things that have significant elements of single payer or public option without calling them that. And at some point, someone will look up and
that's what we have right now.
Right, exactly.
Like SAFE, that wouldn't be bad. Things that look like the way SAFE conducts.
Yeah, that as a model, intellectually that's right. There are some politics with SAFE specifically that you introduce that are a little harder to manage or a little different. So I probably wouldn't go running around saying that's what I was trying to do, but yeah, you're right.
Follow up. Yeah, actually, completely separate question, but in the phone call conversation that I was involved by phone with the committee on whether the
assessment,
one of the things that I was surprised by, maybe shouldn't have been, is that the individual market is separated out in its own marketplace, not associated with group plans. And part of the view of that individual plans are too expensive, or that's the complaint. Is there a move to say, hey, insurance is all about the pool. The larger the pool, the better it is. To make it all one pool? Is there conversation about that?
So market merger was one of the ideas that was on our list of 9 or 10 ideas that was to go at exactly that, and that can mean different things in terms of individual market, small group, large group, those kinds of things. Reinsurance actually goes at the same thing, because for reinsurance to work, if you follow the model from the Oregon Medical Insurance Pool or the current reinsurance plan that's just now expired, you're assessing the whole health insurance market to do whatever you're doing with the reinsurance. And so when we're talking about this reinsurance, it's the whole market to reinsure the individual market. And so what that's doing is effectively the same thing. It's spreading that excess risk in the individual market out across a much larger population.
And is that an easier way to do it as opposed to saying, okay, if you offer insurance in the individual market in Oregon?
Well, it's easier if you're talking about a relatively small increment. We're talking about reinsurance that would have an effect of lowering rates by something like 3 to 5%. We're not mainly doing it to lower rates. We're mainly doing it to calm the market down and make them comfortable with the risk they'd be taking on. If you wanted to lower rates by 25%, that's probably not an easier tool than something that's more structural around the risk. But you're getting at the exact problem, and it's what Congress is struggling with, and it's part of what they don't understand. What Stephanie was talking about is, I'll just use the Oregon numbers because I know there's 150,000 people in Oregon who are really upset because they are the individual unsubsidized market. And their rates have gone up a lot, and there's some arguments to make about that because they were really low to begin with, but they're really high. I mean, it's expensive, right? It's $12,000 a year for people of a certain age.
Well, just so you know, the really low that you're talking about was 20% higher than my previous.
Correct.
Yeah.
No, and the reason for that is because you were medically underwritten. And so you had insurance that you could qualify for because you were healthy, and it was probably not as good an insurance as you might have hoped in many cases.
Terrible insurance.
Yeah, right. If you actually got sick and needed it, and so now you have better insurance, arguably a good thing.
Yeah, maybe.
Right. But you're kind of solely paying for the excess risk of the people who couldn't get insurance before because they were sick. And really the trick is
in a really small pool.
Yeah, and the trick is to figure out how to spread that excess cost out over a wider population. And then you really get to the single payer argument. Taxes is a great way to spread a cost over a large number of people, but that's not really quite where we're at yet. So that is the problem. And so what they ran into is they didn't realize, or were ideologically driven to not care, that to fix the problem presented by those 150,000 people, they were proposing to take insurance away from 400,000 people.
Right.
And that political math doesn't work very well. And so they're stuck on what are they trying to solve for. The Freedom Caucus she was talking about is solving for a whole different issue, which is the federal government should not be involved in health insurance, and so 0 people covered is a win.
Yeah, right.
Most of us are on this table and across the aisle in Oregon are solving for how to get the percentage of people covered up to 100%, and do it in the most effective, cost-effective way, and all those kinds of things. It's really two different.
Well, so one of the things, and now I think there must be data available about the churn. So are there small group small employers with small group plans or large group plans, because there's an individual market, that are shedding their insurance, and the employees are now going out on the individual market?
Not a lot of evidence for that. What there is evidence for is the other direction, which is employers going to self-insured and taking themselves out of the insurance market completely, which is actually even worse.
And there's family glitch that kind of reinforces that as well,
right?
Because all of the dependent coverage writes them out of the individual market.
Is there hard data that how would you track if an employee or an employer drops health insurance?
Well, you just look at the net numbers of coverage. and the combination of the individual market and the small group market, you're not seeing an erosion of small group that's being offset by a corresponding increase in individual.
Oh,
Where you're
no,
seeing
I thought
is
we did hear that last fall, that there was some stronger.
well, not. I guess I'm saying it's not a one-for-one trade.
Yeah.
There is some decrease in the small group market that's more than offset by increase in
And they're expected to see a lot more shit.
Right.
Right.
But what there is data for, and if you talk to agents, they know that they talk to large groups, and actually the Congress, the House today, U.S. House passed a bill on stop loss insurance to make it even easier for smaller groups to self-insure. So I think that's the biggest fear we have right now.
Is there anybody on the phone who has any questions or comments? All right, well, I guess we are good to move on, although I would like to just put in the request that when any of these legislative concepts are ready for folks to look at, if you could share them with the committee, I think that would be deeply appreciated. Yep. Thank you. All right, so now we are going to hear a presentation on the oh so exciting subject of health savings accounts.
Very
Screen
I
enough?
remember the conversation last time about that.
Okay. Hi, introduced myself earlier, but I'm Michael Schroff. I'm a performance improvement advisor with the Oregon Marketplace, kind of filling in the shoes, filling the position formerly occupied by Deanne Gilmore, who has gone into part-time retirement. She's dropped down to, I think, officially a 0.75 FTE through June, so I'll be back up to talk about enrollment numbers in a little bit too. Just from kind of shift over, I know this is a scintillating topic to talk about over lunch, so please bear with me. I'm going to start with a really high-level overview of kind of the very basics of a health savings account, what it is, and in particular, I think what's of interest to you folks will be kind of how these tax-preferred accounts are connected to health insurance coverage and the interrelationship between the two, and then we can hopefully kind of segue into a bit of discussion about how that might play out for the Oregon Marketplace. So what is a health savings account? This is relatively straightforward. It's essentially a savings account for health. This is a creature of tax law. It is not an insurance plan of itself. It is a tax-preferred trust or custodial account maintained by different qualified entities that provide certain tax benefits. So what are those advantages? On a high level, if you're familiar with 401ks or IRAs, it's very similar to a retirement account, but with an added healthcare component. Basically, the money you put into the account is exempt from taxation. The money that's in there can earn investments, can be invested and earn interest or other distributions. That income is also tax-free, and it has the added advantage of you can take the money out, and if you use it to purchase out of certain qualified health expenses, it remains completely tax-free. So you can process it through the HSA, back out, and essentially escape taxation on dollars. How is it established? You can do this on your own. You can work with a qualified trustee. That's usually a bank, an insurer, or what I call the TPA. That's either a brokerage house, some kind of investment firm, and they will set you up with one. The vast majority of this generally is going to occur within the employer group context. So the employer works with one of those entities as part of their comprehensive medical benefit and offers the employees HSAs. Who is eligible to get or establish an HSA? You have to be what the IRS calls an eligible individual. There are basically 3 rules for that. Number 1, you cannot be claimed by a tax dependent by somebody else. You cannot be enrolled in Medicare, and you must be covered by something called a high deductible health plan. So that's sort of one of the keys to entry. To get into an HSA, So you have to have the high deductible health plan and generally no other coverage. So you have to have high deductible plan and no non-high deductible coverage. There's some exemptions on that, but that's sort of the gist. Important to note that these requirements apply to establishing the account and contributing to it. It does not apply to taking the money back out. So this is how you get the money in when it comes back out. Even if you cease to meet these criteria, you can hold on to that HSA and continue to make payments out of it.
Michael, it's worth mentioning maybe too that HSAs have close cousins that have different sets of restrictions that are different, especially that high deductible health reimbursement arrangements, for instance.
Yes. So yeah, the HSA is kind of one of sort of the alphabet soup of healthcare. Some of these different tax arrangements that are out there. There's also the HRA, the FSA. Going back a little bit in time, there's an MSA. They're all related. They have some and you get in the details, there's some different rules. I'll touch on a couple of those as we go through. This kind of category is sometimes referred to as sort of consumer-directed healthcare, with the idea that rather than being, all the decisions being made by the insurer, you're kind of creating these accounts, giving the dollars to the members and sort of letting them having a greater stake in their healthcare decisions and directing where that money goes. So back to high deductible health plans. There are a couple high-level requirements to be a high deductible health plan. It's sort of the gateway to creating the HSA. Generally, these are going to be health plans that have, I'm going to say, high deductibles here, getting more and more to market average deductibles. There is actually a statutory minimum, so it has to at least be 13. These are 2017 numbers, by the way. They do kind of inflate over time, but it has to have a deductible of at least $1,300 for self-only and $2,600 for families. In practice, depending on which metal level you're looking at, your deductibles are going to be about at least double that. If you're looking at a bronze plan, you're probably more concerned with this middle category, which is the high deductible health plan has its own out-of-pocket max. Similar to the ACA maximum, it's actually a little bit lower because these predate the ACA, but they're very close. So $6,550 for self-only, $13,100 for families. The other key kind of distinguishing feature is a high deductible health plan generally subjects all the services and all reimbursements to that deductible. There is not really any first dollar coverage, with an exception of preventive care. So these are kind of the broad categories of preventive care. These are the things that you can, if you're an insurer trying to design a high deductible health plan, you can provide these ahead of deductible. You're not required to. I believe most insurers will. The bottom category, with the exception of the bottom category, that they are subject to the ACA requirements for preventive services without caution. So there's kind of two separate lists here. These are the services that all health plans have to cover, and they have to cover at no cost. So if you're enrolled in a high deductible health plan, you can establish the HSA. You can then contribute to it up to these are the maximums for tax-free, so up to $3,400 can go into your HSA, $6,750 for families. Individuals over 55 or older can contribute an additional $1,000 a year. The idea that is similar to like the retirement accounts, that if you're a little bit older, you can contribute a little bit more. And kind of the key point, where these kind of really come into play, is the employers are also allowed to contribute to an HSA. Employers can also contribute to an HSA, and that their contribution comes off of that total limit. But that's something that a lot of employers have moved to as the premiums on health insurance have continued to go up and up. They've started to go to these higher and higher deductible plans, but then pairing that with an HSA and just giving the dollars back directly to the employees. So that's how the money goes in. This is where it comes out. Basically, there are IRS rules on what they consider qualified medical expenses. Without going into a ton of detail, this is generally most things you would think of as out-of-pocket expenses for medical care for either the account holder or his or her tax dependents. So it does not include premiums generally. So that is usually what we're talking about is like cost sharing, copay, deductibles, things like that. That is a distinction from the HRA, which does have limited use where you can use an employer-sponsored HRA to purchase individual market coverage. I mentioned that because I suspect that there was a bill that passed, we talked about it, I think, last time. We may be back talking about that soon as we see how that starts to interact with exchange plans. Historically, originally, an HSA could be used to cover over-the-counter medicines. One of the ACA reforms, they prevented that. Put a limitation. You can use it for over-the-counter medication, but you have to have a prescription from a medical provider. Timing. Generally, your expenses can only be reimbursed if they are incurred after you establish the HSA. If you are not prohibited from taking money out of your HSA for other purposes, but it is subject to penalties. So whatever amount you take out, if it's not substantiated as a qualifying medical expense, the amount of that distribution becomes taxable income to you, and you're subjected to an additional 20% tax on that same distribution. So generally, although it's not impossible, generally once the money goes in, it pretty much needs to stay there or come out from medical expenses. And similar to these other kind of retirement accounts, you can roll over from one HSA to another. That's not a violation of the distribution rule. Well, actually, you know what? Let me pause here for a second because I know I went through that really, really fast, and just see if anybody has any questions or comments on around of how the HSA kind of interacts with the high deductible health plan and kind of how they work, where they come into play.
I have one question about secondary coverage. If an individual has Oregon Health Plan secondary to their employer-sponsored high deductible health plan, would that make them ineligible for the HSA?
I don't know for sure, but I think it would.
Okay.
Yeah, generally the idea is, kind of the policy concept, as I understand it, is sort of you're exchanging this tax benefit for the high deductible.
Right.
And so the reason they say if you can't be double enrolled, they want to basically be subjecting you to that high deductible. So I think that Medicaid would outrule you. Things that are allowed are things like, accident-only coverage, dental-only coverage, vision for limited benefit plans. So things where you might have some medical coverage through different plans, but not really what you would consider another major medical plan.
So I just have a comment. I'm not sure what comes next. So
sure.
So I have a HSA plan. We're on Subble. Don't use my health insurance really at all. And I have just gone through an episode with an HSA, and a huge myth, in my opinion, and I'm an individual, not an employee. I'm not under an employee plan or an employer's plan. There seems to be absolutely no cohesion between insurer, HSA, account holder, or institution, or a third-party provider for services. And so I don't know how far you're going to go with this, but if HSAs are going to become much more of a standard, or employers are going to whatever,
yeah,
that is a huge miss. I consider myself a fairly intelligent person.
Yes.
We do too. And find it
yeah.
Very different. I have an account that I can't access now.
Yeah.
So,
yeah. And I think like your health insurance.
Absolutely. Yeah, I've got the best in the whole world. I can't access healthcare or the money to pay for it.
You're absolutely making kind of a point that, I'm actually kind of in a similar boat. I don't have a high deductible. I came out of Providence in December, Providence Health Plan, to come back to the marketplace.
What is Providence?
Yes, we had an HSA, so I'm in that place where I have leftover HSA funds. I can still use them, but I can't put any more money in. So I really enjoyed my HSA. I happen to work in health insurance regulation. So it is, with respect to the individual market, I think there's a couple points here. One is, part of why we're seeing a lot of popularity of these arrangements in the group market is you have that employer and some benefit people. They're either working with an agent, they may have an in-house benefit department that can kind of help package that together to an extent and kind of provide that support of both, here's the plan you need to take, here's your account, here's your employer contribution. Looking at these from an individual market perspective, you're sort of on your own to put that together. So that is going to be very difficult to navigate for, a lot of our enrollees.
Well, and I guess one of the, I didn't think my last 3 days on the telephone with all these people was going to be so apt to the agenda, but actually I was doing my research. What I was struck by is if maybe this group or DCBS has any chance of regulating. I had gone into a high deductible health plan with another insurer that said, hey, we've got an HSA and here's the bank, and kind of made it easy. So then they pulled out of the market. And nobody could tell me. I mean, I probably called 3 times to say, okay, I've got a new insurer and I've got this account, but I don't know how you know each other and how you relate to each other. And so when I tried to go to make the contribution actually for this year, somebody said, oh, you need to have a new account number. So, okay, great. Sends me the card. I log in. Oh, but that's my old insurer's card. So if DCBS has any control over, there's got to be a way to transfer, to help the customer transfer through that maze of administrator, financial institution, health insurance provider.
Yeah.
Or plan provider.
Yeah, and the challenge is, kind of the way it's conceived is these are sort of independent pieces, right? You've got the health insurance piece, you've got the tax piece, you've got the banking piece.
Right. But
they're meant to work together, but yeah, it is difficult without someone to facilitate.
Yeah, but sold as a package to begin with, right? And so now I find out insurer pulls out, so plan's no longer available. So I'm signed up with somebody charging fees to that account that I am unaware of. Nobody's ever talked to me about there's fees, and to terminate, to roll over that account, there's a fee to roll it into a new institution. I got off the phone and just said, well, I feel like I was scammed trying to do the right thing, picking the right plan.
Yeah, we should look and see if we've got what kind of regulatory authority we do. My fear, you'll remember Michael started this whole thing off with the notion that this is a creature of tax law.
Yeah.
Which my fear is we don't have a lot of authority, but we can look into that and see if we got.
So you have to send a long letter to the insurer. Or I use the online deal to just say, here's my experience.
Yeah.
Can't happen like that.
Yeah.
Everybody should always do that.
Yeah.
Having a paper trail with DCBS is a good thing.
And that's why I did it. It's like, okay, I know there's a lot that's complaint driven, but I was horrified by this experience. And now you can't get out of it, Think, okay, now what?
Yeah. Well, go ahead.
I was just going to ask, do we have any data on how many Oregonians have an HSA or have an HSA compatible plan or anything like that?
Yeah, so I'll give you the figure I have. And it's not a great figure, it's not a DCBS figure. Where it comes from is from America's Health Insurance Plans. They do an annual survey of their insurers and sort of try to get some information there. There are some proprietary databases on HSA data, but it's not something where the IRS makes this publicly available. But AHIP puts out a report, and they estimated about 120,000 HSA, HDHPs in the state of Oregon.
Just on the private or in the employer?
Yeah. Now, the other thing you need to understand, though, of that number, nationally, they figure about 78% of these are in the large group market. Right. So they're in that employer context. Another 12%, the 12% is in the small group market, and just about 11% of that is actually in the individual market. So it's not clear if those are folks that established them in the individual market the way you did, or if they're people who maybe had them coming out of groups and just sought out HDHP coverage to continue.
Well, I would be curious how somebody comes out of a large group plan to where they have an HSA, they change jobs or whatnot. So are they caught in my situation? You've got a new insurer, a health savings account, with no way to, and truly I don't have a way to access.
Yeah.
In fact, they told me I had to close the account because my administrator was on the account. It's crazy.
Yeah, no, that's from an agent's perspective. It's really, when you set up an HSA or high deductible health plan, so many of the carriers say, oh, do you want to use our TPA to set up the HSA account? And it seems like not a good idea, especially when there's so much volatility in the individual market. You can go with a different carrier every single year. So thanks for the consumer insight.
There you go. I'm happy to do it.
When I put people into HSAs, I check their bank to see if their bank has an HSA account or where bank is located as well, so they can access it.
A lot of people do employer. They'll do an HSA for an employer-provided plan, but not an individual.
Michael, do you know if in that AHIP survey, did they indicate how many of these accounts are funded by like an employer grant to the holder, and how many are people self-funding drop by drop into their HSA?
They do, but I don't happen to have it off
in
my short-term memory. Yeah, that information's out there. The vast majority of contributions, I want to say this right, if I remember right, not that the vast majority of contributions are from the employer, but where you see individual contributions are almost always paired with employer contributions. The vast majority. So it's something, I think a lot of people are probably in my situation where they had it through an employer, they still have it, and they're sort of running out the string. I don't want to suggest that nobody does, what you're trying to do in terms of trying to, do this on your own, but it's not easy to navigate. And I think, but particularly for sort of our population, a lower income population in many cases, that with the subsidies, I think it'd be that much more difficult and challenging to try to navigate that three-headed monster.
Well, I think in addition to that, if you're self-funding your HSA, really the only benefit is the tax exemption on that money. But if you are low enough income that your tax rate is very low to begin with, the actual dollar benefit to you is pretty small, especially if then they have to spend all their free time going through what you've gone through.
Right, and I understand that I am a small subset, representing a very small subset for what this group represents, but it's the group that happens to pay for their.
Oh yeah.
It's the group that is supporting the Freedom Caucus or whatever, and it doesn't. I don't happen to be one of those people, but I am pretty crazy about how it works for those people that are on the hook to pay for it and to navigate through it.
That does bring up the political question of HSAs, because in conversations I've had with people of that political persuasion, they're big promoters of the HSA as the solution, as the...
This is vested with magical properties.
Right, I know.
All you need is a lot of money.
Yeah.
Right.
Yeah, right. And I'm beginning to think it's a really narrow band of people, either who, because the employer is looking to reduce their costs, much as in my industry, there are people going around saying, we'll buy your employees, they'll work for us, and you don't have to pay. There are all these scams, and it begins to look like that. But so what are the weaknesses beyond that? Because it seems to me they're significant if, one, if you don't have medical problems and the money is just sitting there, or if you do have medical problems and there's this big gap that suddenly you can't make between what you might have been able to sock away in the HSA and where your insurance coverage actually begins to pick up.
I think the right way to think of these is as an investment brokerage vehicle that has some health-related features to it. And if you think of it in that context, you're right. There's a narrow band that it makes a great deal of sense for. But it makes sense if what they need is an investment vehicle that they want some health features to, rather than it being primarily a health vehicle.
Right. Not many of mine.
As a health vehicle is the way to spend your own money on your health care.
Yeah, we have, so I have one through my husband's employer. We are two very healthy people with young children. We don't have a lot of medical expenses. We made the calculation, you know, if a more catastrophic thing occurs, we have financial backup.
Yep, and that was.
And we wouldn't do it otherwise.
And does the employer fund it, or just?
I think it's a bit of a, I think it's, my husband, so I forget a little bit, but I think it's a bit of both. Yeah, I think it's a bit of a match. So, but you know, we're not paying, all we get is preventive care. So if it's just a primary care visit for a cold, we are paying that out of pocket.
But just on the plus side, and one of the reasons I got an HSA is one, I had heard some rumblings that HSAs were coming, so I thought, I'll just experiment with this and kind of see how it is. But the plus side is, and I think what the more conservative members of the Congress talk about, that I would agree with, is when you're paying for your own health care, as opposed to the third party who you have no idea what is being paid or nor care. When you're paying for it, you do consider, I mean, I do ask, what is the cost of this this service, whatever that is. So there's an awareness of it, and that's one of the things I've heard about HSAs is prior to the ACA is people would use their health savings account and negotiate for health care. I mean, they'd be quoted $400, and they'd say, well, I'll pay you $250.
My hand went numb one Christmas. I had no use of it. I can assure you I did not start calling around and say, what do you charge for TIA procedure? What am I going to be?
You might not for that, but you might for a knee replacement surgery that you have to have, but you've got more time to make that arrangement. And that's where I heard it used is, you know, yes, I seek healthcare, but I'm more, I am certainly more aware of the cost of healthcare and how it differs from it.
I have a lot of thoughts about this and would love to talk about it more, but Michael has some more.
Actually, this is sort of, I appreciate the back and forth here. I think we're kind of hearing, I think you're doing a very good job of sort of the debate, sort of nationally, and the perspectives on these things, who they're good for, who they're maybe not so good for. Sort of, I guess the last thing I had was just sort of, part of why I think this comes up and became so pertinent is when we were looking at a lot of the possible repeal and replace scenarios, proposals. Almost all of them had something to do with HSAs and improving, expanding HSAs. So it's something that it's important to be fluent with. It may, you know, as I said, right now it's a relatively small sliver of the individual market, but depending how things shake up, it's good for this group to be thinking about and aware of them. This sort of a distillation just of what this really is what the American Health Care Act would have done with HSAs. So I'm calling it possible future changes. An early iteration of the slide was, you know, HSAs in the AHCA. So some of the proposals were basically increasing, and they're variants on all of these themes, but increasing the allowed annual contribution. AHCA would have actually increased it all the way up to that out-of-pocket max. So instead of the $3,300, it would have gone all the way up to the $6,500. So basically, all of your out-of-pocket max expenses under the high deductible health plan could be filtered to the HSA and therefore be paid on a tax rebate. They would have basically repealed the couple ACA provisions. ACA actually increased when we talked about that 20% penalty tax. That was an increase from, historically it was 10%. ACA increased it to 20%. Would have repealed that, put it back down to 10%. Also would have reauthorized the use of the HSA for over-the-counter medications without a prescription. Couple other ideas that were in there. This gets really down in the weeds, so forgive me. But right now, we talked about the catch-up contributions. Right now, a married couple that they can be independently eligible for catch-up contributions, but they must be made to their individual HSAs. So, you know, my wife was eligible for contribution. She'd have to have her own HSAs and contribute that extra $1,000 into that. They would have done away with that and basically put that and let both spouses share. Last one is the timing rules. They would have loosened up those timing rules. I made the point earlier that the HSA, you can only use it to pay expenses incurred after you establish the HSA. They would have loosened that up to about so if you established the HSA within 60 days of enrolling in the high deductible health plan, you could go all the way back to the start of the plan year. One that was in an earlier version, it's not on this slide, but one of the concepts when they talked about the fixed tax credits under the ACA is that could have actually been, if you had any leftover balance at the end of the year, that could have been rolled over into your HSA, which is a really interesting idea, and it kind of just wanted to mention that. It ended up coming out in the final draft, but it was a concept that's been floated of sort of actually having, in addition to having employer contributions to an HSA, potentially some level of government contributions. So that's, again, that hasn't moved. You know, those are kind of some of the ideas we've been hearing and in this market space. And as I think Jim noted, you know, there is a sense in some people that this whole thing can just be fixed if we just had bigger and better HSAs.
We have bigger and better paycheck.
Yeah, there's with that.
That's really all I had, other than trying to kind of, I think, hopefully facilitate a lot of the discussion I think we had. If there are any other questions, I'm happy to take them. Hearing none, thank you.
All right. I guess I should ask, is there anybody who has a question or comment from the phone? I guess not. Well, we are right on schedule, which is great. So next we have an update from the 1332 subcommittee work from Katie and Anthony.
Ow. That's why I let you take that seat.
Good afternoon, everybody. Brought my own. So we just had a very brief update about the 1332 waivers. As you might recall, last year we convened a stakeholder group to talk about potential waivers that the state might want to apply for. That group primarily focused on vulnerable populations, not so much on market stability concepts. And recently, within the last probably 3 weeks, March 13th to be exact, HHS sent a letter to the governors of all 50 states about 1332 waivers, kind of encouraging states to apply for those, but the letter was very much focused on state reinsurance programs and state high-risk pools. And so we took a look at the letter, and the letter mentions a 1332 checklist that's supposed to be coming out in a few weeks, and not seen that yet, but hopefully at some point, maybe after the Easter break, it'll come out. So we looked at the letter, we kind of talked internally and came up with kind of a plan of action based on kind of the information that we had from feds. One thing to note is that there was no indication that the feds were going to kind of relax the standards. So the standards remain very high for obtaining a 1332 waiver. It's basically a 12 to 24 month process. So with kind of all those things in mind, we developed kind of a plan going forward. We're going to wait till the checklist comes out. We're going to have a look at it, and then we're going to schedule a meeting with HHS to talk about the checklist, to get some clarification on whether or not the requirements for 1332 waivers will change, maybe become easier, or if maybe HHS is going to take more of a cursory approach to reviewing those waiver applications. And we also want to discuss how potential legislation might impact 1332 waivers. It's unlikely they will have much to say on that. But anyway, those are kind of the topics of discussion that we wanted to approach HHS with. After we had that additional information, it was our thought then to reconvene the subgroup and brief them on what we learned, and then kind of decide next steps from there. Katie, did you have anything to add? So
You said everything that I told you to say.
Katie is the brains behind the duo. I'm just the pretty face. So anyway, I'm happy to take any feedback from you all if you think we should maybe modify our approach or take a different approach. Happy to answer any questions if I can.
I had not heard about this idea of a 1332 checklist. What would that be exactly? What I mean, the government already has some fairly specific requirements for the waiver. What would be on this checklist?
Yeah, so that's a good question. The checklist is described as something that will assist states with 1332 applications.
I think the idea is that the CMS waiver process today is perceived not inaccurately as a bring me a rock exercise. There's all kinds of requirements, and you go bring them something, and the answer is that's really not quite what we were looking for. We'd like you to bring back something different. And I think what this is aimed at is trying to say if you do these 7 things or fill out these 7 forms or whatever's on the checklist, then that's what you need to give us, and we'll give you an answer. It's the streamlining concept that they're interested in.
That would sure be nice. Yeah.
I would just comment, my understanding is that the Alaska and then especially the Minnesota waivers on reinsurance went through really quickly. And so I think the steps are right. I think we should prepare for that to potentially be a fairly compressed timeline, because especially if it ends up being part of the governor's budget, we're going to want to move really quickly on that.
We already have the legislation that says
it ends up if it's part of the budget, it'll end up in a budget bill.
Okay. Yeah.
So, yeah, I'm not quite sure. I mean, I think your approach to this makes total sense. I don't know if people have questions. I guess the only thing I wonder about, and I don't know if we have enough information to address this, is whether what the administration is saying is just that they want states to do reinsurance and or high-risk pools, or whether there's more to it than that, or whether there might be some flexibility to do something that you could say was a high-risk pool, but actually did something good.
Well, reinsurance would be something good.
Well, right. But I mean, like, is there something we could do besides the reinsurance program that might be even better? Right? We're in favor of reinsurance.
Especially when it uses federal money.
Absolutely.
I think that's one of the discussion topics that we'll talk about. I mean, in reading that letter, it seemed pretty clear to us that that was really the focus. But maybe everything's streamlined. I don't know, but hopefully that's something we'll be able to find out.
They're also, I mean, the big piece of streamlining that they're likely to do is on Medicaid waivers, which isn't our bailiwick anyway, but well, every version of providing states more flexibility and being more streamlined is how can we help you do drug testing for Medicaid? How can we help you do work requirements for Medicaid? How can we help you get able-bodied people off Medicaid? That kind of stuff.
That's great. Yeah. How can we help you impose our requirements?
Has there been any movement on the smaller recommendations, like increasing utilization of CCOs or the wraparound programs or anything like that? Any changes?
There's been no movement on. Well, I'm sorry. Our version of the contract is not complete yet, but those are items that we were looking at putting in the contract. We're now even, I guess, maybe in a we have less leverage with the carriers than we did before, which wasn't very much. So those are things that I think we need to approach carriers with first, without scaring them away. They're already a little skittish, you know. I think.
Yeah, and there were a couple things that were on the list. One of them was Representative Kotek's, which I have not followed, to cover all.
Immigrants under.
Yes, thank you. Under the 5-year ban. And then also one of the other recommendations was to look at the bronze plans and the silver plan stuff. And so I've actually finally gotten some things from CMS and the screenshots that you sent were really helpful. So there are some things that we're kind of moving on, but yeah, those kind of other things that we're like, maybe we should do this, maybe we shouldn't, have not really been fleshed out yet.
Seems like a tough session for them anyway. So
Yeah, there's, as Pat said, there's so much extra money to go around, so.
And cover all kids is likely the place where there will be coverage expansion.
We should cover kids.
Really, oddly.
All right, any other questions, comments? Anyone on the phone? Well, that was ruthlessly efficient. We are now ahead of schedule. And it's time for our open enrollment wrap-up.
I'm just wondering if it might be timely to allow people a somewhat longer than 2-minute break for.
Since we are well ahead of schedule, let's go for a 5-minute break exactly.
Go quickly.
Hi everyone on the line. We're getting started again a little later than I intended, but that's fine. It was brought to my attention that there was actually sort of an action item with the last item that we didn't explicitly address, which is they were asking that Katie and Anthony were asking for our approval to go forward with this. And we don't need to do a motion, but I just wanted to kind of explicitly put that on the table, and in case anybody had any qualms or additional questions. No? All right, you have our blessing. All right, so let's move on to the open enrollment wrap-up.
I guess I'm back. I'm gonna start. In your packet, I think I'm gonna start, and then Elizabeth's gonna take over with a PowerPoint and go through some marketing information, but don't have really a presentation. We'll put it up on the screen. There's in your packet, you've kind of got about 4 pages of some numbers, enrollment data. Just wanted to check in with this and see what questions we might have. That first page you've got just says open enrollment summary up at the top. This is sort of the snapshot we get. This is our final end of open enrollment sort of information from CMS. This is, we talked about this last time, so it's sort of a follow-up, but this is sort of where we landed by the end of open enrollment. This is planned selections, not effectuated enrollment yet, but I think last time we talked, we had about 148,000 people who had selected a plan through our marketplace. We closed open enrollment with 155,430. So we were up a bit from where we were. Part of why it's not as big a change from what you saw last time as we might have expected is we continued to see restatements of re-enrollments from CMS. So they kept what actually happened is for last time we were talking through week 10, they actually had this incorporates weeks 11 through 14. What we had last time, so what we actually saw was we continued to gain new members every week pretty consistently, but we also had corresponding, they're taking away re-enrollees. Basically, they had some people double counted. So we closed pretty strong. Week 14 was actually just 3 days, this open enrollment. It was January 29th through the 31st. And we had 4,492 people come in those 3 days. So we did very well. If you remember, this is about the time that Trump administration issued the executive order. They pulled all the national ads for healthcare.gov. Oregon really stepped up to the table and did some, local state advertising. So while we saw a bigger bump last year and so we were a little bit down relative to that, but relative to most of the rest of the country, we did very, very well. We closed very, very strong. So,
yeah, the average, the market-wide average was down 7%,
yeah,
I think, and we had a very slight uptick.
yeah, we're about 6% up from where we were last year. Yeah, so we continued to grow. We didn't grow as much as maybe we hoped, but it's actually very encouraging, at least to me, that we kept growing. All of this on this first page. Sorry, I do have an effectuated number for you. We've got our first round of assessment data in. Just came in this week, a couple days ago. So we had 155,430 had selected a plan by January 31st. As of March 1st, we had 136,615 effectuated.
Premium paid. Okay.
Yes, so that is where the carriers are actually saying, yes, here are our current fully paid members as of March 1st.
About 85%.
Yeah, yep, yeah, and that is right where we were last year as a percentage of our effectuation rate, so.
That'd be 8%.
Yeah.
So I'm sorry. So the effectuated number is the same as last year, but the total plan.
Right, the effectuated rate.
Percentage. Sorry. So in terms of the people who go from selecting to actually being, enrolled, that percentage held true this year relative to last year.
Okay, so 136,615 effectuated this year. What was that number last year?
I have that. 129,243.
Out of 140 something, right? 147.
Yeah, sorry. Yeah. 147,108.
Sorry, one more question regarding data.
Sure.
Where were we at the end of as of December 31st for effectuation? If we started the year with 147, how many did we end up with at the end of coverage here? Did we retain at 87, 88%?
Oh, for January.
Effectuation rate?
Well, so I can get you that, but so the 1-1 effectuated, that would have been everybody through December 15th. When it's selected the plan through, because that's the cutoff for the 1-1 effectuate date. So I don't know if I have it.
No,
I don't have that handy.
You're thinking of 2018 plan year data as of 1/1. You're talking about how did 2017 plan year end, right?
No, 2016.
2016, yeah.
Right. Are you saying how many did we have enrolled
at the end of the year?
Pretty much at the start of March of last year, at this time, we were at 88%, 85 to 80% effectuation rate. So how did we end the year with?
Yeah, on December 31st.
Right.
Was ours.
For 16 plan year.
People kept their coverage all year.
Yeah, they kept the coverage all
Well,
year.
it's not quite as simple as that because of churn, right?
Yeah,
Right.
Yeah.
Most people are
I mean,
and that kind of thing.
I don't have that handy.
Sorry.
No, that's okay. But it was way up. So
Okay.
yeah, kind of during the year you tend to lose. So then open enrollment sort of refresh.
Yeah.
Yeah, and then you start to lose. You kind of have attrition during the year.
Yeah, what you're looking for is the attrition rate changing. Right.
And how we can adjust, especially with a shorter open enrollment, how we can make sure all these different changes in place keep that rate or even improve that rate.
Right. I mean, if for some reason it's sticking in my mind that we end the year at about 75% of what we started the year, but I could be completely making that number up.
It feels like a good ballpark, but
So it would be interesting to know whether we ended 16 as more or less that same spot.
Yeah. The rest of this is very much consistent with what we've seen historically in terms of percentages. The growth is pretty much proportionately spread. No major significant changes from what I think we looked at last time. So that's just sort of the snapshot, high level of the demographics and the information that CMS gives us. The second page you have, and
Can I ask one question on the metal level? Do you have those numbers for 2016 for bronze, silver, gold, platinum, catastrophic?
I don't have that on a metal level basis.
Well, somewhere we do, but not.
Yeah, sorry. Yeah. 2016, the metal level breakdown at the end of 2016 open enrollment, right?
Just comparable.
In terms of did people move? Did we see any movement across metal levels?
Do platinum plans exist?
Not at the moment.
Okay.
Not. No, I don't think there are.
There are zero on
There are some talk about it, but not in
Yeah, we don't have any platinum plans on the marketplace in 2017.
Do we have some information on how many people enrolled with assistance, meaning with somebody helping them as opposed to the financial assistance numbers?
Yeah.
That's by financial assistance, not the person helping them. Right. Because we had some number in the report at 10 that was about like 37% or something like that. I wonder if we could get a 38.
Oh, no, it's 40. It's in my marketing.
Okay. But do we have the final for that somewhere? That's financial assistance.
So with
Yeah, so sorry, yeah, under the program eligibility, that is the people who got subsidies one way or the other. Yeah.
Right, yeah.
But yeah, you're talking about the new piece that we had last time, which is how many people indicated that they used an assister, which was new for this open enrollment.
Right, yeah.
Yeah,
you got a final number for that if you're curious.
This is sort of a random question, but do we have a theory about why so few people sign up for the catastrophic plans? I wouldn't necessarily advocate that we try to have more people sign up for them, but I actually find it kind of confusing that there are so few people who sign up for them.
A big piece of that is tax credits or cost sharing reductions are largely more available. It's only available through silver level plans.
Right.
So that's when we do that. I see Katie fiercely raising her hand. Catastrophic plans aren't statewide, so they're only offered, I think, in 2017, I think only Pacific First and Kaiser offer them, and they have narrower service areas.
And they're fairly costly.
They're only available to people below a certain age.
Right.
Yeah.
And then a couple other loophole provisions that allow you. And Katie, am I right that you can't use a tax credit on a catastrophic plan?
Use a
You
tax credit,
can,
but not.
but you have to be 30 or younger or meet the hardship exemption, and in Oregon, you're unlikely that you're going to necessarily meet the hardship exemption with Medicaid, so.
The age issue is probably the big one because the fundamental issue is that age band isn't buying a product at all.
I mean, we do have almost 12,000 18 to 25-year-olds signed up, and those would seem to be the demographic.
Yeah, they were put on by their parents on their parents' plan.
Yeah, and especially like in our state where sometimes in other states they offer some offices if there's something on the catastrophic plan, but they don't on the bronze, but we don't have that here, so. And for 2018, we're preserving the same metal levels, right? We're required to have. Yeah.
I'd like to ask for some clarification because I know the people here know this. So tax credit isn't available for a bronze plan?
It is.
Incorrect.
Cost sharing.
Cost sharing is not. Okay, cost sharing is not available. So does it make if somebody is encouraged to have a silver plan as opposed to a bronze plan, is it more costly for public dollars if they don't use much health care, let's say 18 to 34-year-olds, don't use much health care? Is it more expensive for the public dollar pool to pay for those silver plans instead of a bronze plan that isn't going to be used?
If they don't use much health care, I would say no, because the tax credit that they get would be the same regardless of their plans. Ultimately, they didn't. I don't think.
Because they get the same tax.
Yeah, and if they don't use health care, they're not really effectively getting any cost sharing reduction because they don't have any costs to reduce. Does that sound right?
And that would potentially put higher uninsured, unreimbursed costs onto the health systems and things like that, which might drive up the price.
But if they don't use.
Some of them are going to have the big cost.
Right.
But
I'm
shooting if they don't.
People that don't.
Right,
You know,
yeah.
who are saying I don't need health insurance
because
I'm healthy.
Well, and it's one thing that we've kind of debated or considered internally when we've talked about, well, there there are a lot of people out there who would be eligible for cost sharing reductions on a silver plan and they go for a bronze. Anyway, we've kind of talked internally about, is this an outreach assistance consumer education failure on, not failure, but are we doing something wrong when somebody picks a bronze plan even when they're eligible for cost sharing reductions under silver? And we've kind of tried to figure out, are people not understanding how great the cost sharing assistance is, because it is complex and hard to understand, or are they just genuinely saying, I don't use a lot of healthcare anyway, I want the low premium, and it's something that we've kept our ears open for feedback from community partners and agents and other sisters about what's going on there when somebody goes for the bronze.
And we looked at how our state compares who enrolls in what metal level to the states that don't really have an active state level education or outreach program.
That's a very good question. I haven't done that.
Because that would be, you'd hope to see we're doing better.
Right.
We do have that education component, and if we're not, then
right.
we do need a little more education. Where if we are better, then maybe it's just a consumer deciding that's what they want.
Yeah, I can check on that.
Speaking from personal experience, Elizabeth, depends on what level of cost share is available to
Yeah, that 73% is not going to move a market.
No, and if the price, if they're not getting that much of a tax credit, then they're a healthy individual, they're going to opt for the bronze because they still get the preventive care. So it's about price and about the level of cost share that they get. Inevitably, anybody that gets the highest level, we don't have a problem. They'll take it. That's what they want.
Sometimes, except for unfortunately those who get the lowest cost share have the least amount of resources available to pay for the premium. So it seems like it's $20 a month or $40 if it's a husband and wife, but that $40 for a family that does 139% of the FPL is a lot of percentage of their income,
Where they could pay 7 cents for a bronze.
Yeah, exactly. Yeah.
Right.
Yeah.
That makes sense.
So just one clarification, I just checked healthcare.gov. So the catastrophic plans are not eligible for tax credits. So I think that's probably a lot of why you're seeing such low enrollment. It's bronze, silver, gold, and platinum that you can apply the APTC to.
I mean, that sort of just means that there's no reason to enroll in it at all,
unless you were not eligible for any tax credit and it was a little bit cheaper than a bronze, and you were in that place where you didn't think you were going to use any health care.
Pretty narrow.
And
642 people.
yet socially responsible.
Yeah.
You felt you obligated to go ahead
but you're afraid of the individual mandate. And to Cindy's question, so you were asking sort of about the public dollars on the cost share reduction. So when all is said and done, when it's fully reconciled at the end of the year, there wouldn't be any payments. It wouldn't cost, if they don't actually utilize the cost share reductions, they wouldn't be any payment to that insurance. So
That'd be the cost.
it would be basically a wash. It would just be the tax credit piece that Pat was talking about.
Okay. And if they then use healthcare, obviously it's less expensive for them on that. So.
Right.
Yes.
Another thing that jumps out at me from this data is in the race ethnicity section, only 4% of the enrollees are Hispanic Latino.
0.4.
Oh, that's point.
No, that's Hawaii.
No.
Oh, no. No,
I'm sorry. I was looking at Hawaiian
Point
Pacific
4 is
Islander.
Hawaiian Pacific Islands.
Yes.
Which I believe that the percentage of Oregon that is Hispanic or Latino is more like 10, 12 or something like that. And I'm wondering, I mean, it seems like maybe we're just not enrolling those folks, but it also seems like maybe we're just not actually capturing the data. Maybe they're in the unknown race category.
Yeah, and they changed that this year. I don't know if this year goes there. Yeah, they're.
What is non-Hispanic Latino?
Yeah, I think they actually used to break Hispanic out as one of the ethnicity categories, and then if you didn't indicate, you fell into other. And so then now they've broken it up to Hispanic, non-Hispanic, and then all the other ethnicity categories. So those are being reported separately. So there may be part of that may be how it's being captured and reported as well.
Then immigration status is the other big component of that. Is people who do not have status or are within that first 5 years and are being poorly served by the current structure at the moment. Those are the two biggest drivers. years that I see at least.
I don't know if it's possible to get this data, but it would be nice if we could somehow tease out how much is due to which of these factors. I mean, one of the questions that jumps out at me from this is, does this mean that we need to be targeting that community for outreach more, or if it's due to a data issue or due to status and eligibility issue, then the outreach wouldn't necessarily help.
Well, it still does for Calum and other programs that help drive down hospital costs. So
some of that may be revealed when Michael gets to the next page that includes a column on penetration of the eligible population.
What's the difference? 4% versus 4% of the whole population. Never mind. That's right.
Yeah, so the Who Enrolled sheet, what we did earlier this year, Deanne we had some contracts with urban institutes, and as part of that, we were able to get them to do some estimates for us, what they estimated that the Oregon eligible subsidy population would be. So what you're seeing on here is a comparison of their estimates of how many folks should be within these income bands that should be tax credit eligible, and what, kind of how we're hitting those different demographics. So kind of that middle column, which is penetration of tax credit eligible population. So based on, that's the percentage of UI's estimate of how many there are out there, how many of them we actually got. I will note on those income levels that's a little icky because CMS changed the way they're reporting income. Historically, they reported everybody under 100% as its own income category. They stopped doing that this year, and they threw everybody into the unknown FPL. So CMS unknown, 400 plus unknown is everybody above 400%, everybody who didn't answer, and everybody below 100 now.
Oh, God.
So that's sort of why those, I would sort of pay not a lot of attention on the right hand where you've got that negative 1772, the positive 2072, but within that core tax credit band, the 100 to 400, that's kind of really where we think this is a good indicator. One thing that does jump out on this page, if you look at the penetration on the gender, the female, that's 70.9%. So that was kind of interesting to us that we knew we were, about 55% female, 45% male, so we were already skewed that way, but the penetration even drives that point home that much harder.
The funny thing I've had, it's not a random sample or anything, but certainly a large handful of conversations with people, often who work in the areas that we work, and the conversation is around not being able to get their kid to enroll for insurance. And as I'm thinking about it, invariably, I can't get him to enroll.
When I was with the previous marketplace and did a lot of enrollment events out in public, there were a number of times when a parent or a grandparent would come in trying to, without their adult child, trying to sign up the adult child, which you can't do that. Every time it was a son or a grandson. Every time.
Yeah, they have a short Y chromosome.
So that's going to be a huge, I can see that really driving some of my marketing plans for the 2018 plan year. Is we got to get the dues.
I have that same experience where I have the mom or the grandma come in and, oh, my 22-year-old son needs coverage. I'm like, oh, I'm going to have to meet with them. And overwhelmingly, once they get the information, they're like, wow, that was really easy. I want to do it,
Yeah.
But it's just the getting them to come into you without their mom telling them they have to.
And frustration with the profit. My data set is very small, but it's frustration with the process. They want it to be like a video game.
Make it easy.
Or Amazon, or whatever. And when they're asked for, you have to fax, proof of citizenship, end of application. So that's what I heard.
Cover Oregon. That's what it's going to be. Just as easy as the video game.
Ordering a book on Amazon.
Saying the same thing all again, but the one system.
I think there were several questions about earlier, and I hate to bring this back, but I read this whole section on the back of page 2 that covers the discrepancies maybe that we see in some of the racial and ethnicity categories. You can choose more than one. If you identify as biracial, so those numbers will be few or some. So just, I think that section provides a really good snapshot or just definition or a description of why the data is what it is.
I have a question. The COPA population falls under the Asian Pacific Islander.
Yes,
and what amazing percentage points. And
thanks a lot to CAN and the COPA community, but 300 of that 500 in 61, at least from the COPA.
Yeah, but it occurred to me that the focus on the COPA population looks like it had to have had spillover effects into the wider population.
yeah, I mean 93% penetration. That's huge.
Yeah.
Like extremely huge. Like
So if we get the dental,
yeah.
work on that. I'm looking at work on that. So.
Yeah.
Any other thoughts? Next page is just sort of breakout by county. Average number of plan selections and APTC and average APTC by county.
What is APTC?
Oh, apologies. Advanced Premium Tax Credit. So that's the premium subsidy. Sorry, I know I use those interchangeably. I apologize. I also have comparisons of this. I apologize I didn't get in the packet, but if anybody wants to see it, I've got extra copies. So I broke this out comparing the plan selections by county this year to 2016 and 2015. So basically what that shows is we don't see significant gains or losses in any particular county. So it's pretty much, we were either up a similar percentage, right around 105% increase relative to last year. And just, a few counties were down, but they're generally counties where we had very few enrollments. So,
This doesn't include other subsidies, just tax credits?
This is just the tax credit, the premium side.
But the higher the tax credit, since that's, I think, being driven largely by the underlying income, the CSR should probably be following a similar pattern.
Pretty close.
Yeah, I figured. It's just ages of one wrinkle that can drive your average costs below the market area.
That's true.
Gee.
But again, the more rural counties tend to be older, with a couple of exceptions.
And Representative Walden's district, look at that.
Better than anyone else.
Well, be cautious, because if I can channel my inner Greg Walden for a minute, he would say, well, yeah, you guys imposed a bunch of idiot environmental regulations that took all our good jobs away, and so yeah, you've devastated incomes, and thanks to that, we need more tax credits.
Who was running Congress when that happened? Let me think. When did the House take over?
No, he would talk about timber restrictions that go back to the 90s, early 90s, and Glenn Forest Plan, that kind of thing. I mean, you just have to be really careful with.
It's good. I town hall meeting in my district. I'm in this district. Yeah, next Wednesday I'll be going.
Oh,
so
yes,
maybe we could talk for a few minutes afterwards so I can be prepared to have some comeback.
I saw some of the controversies around those town hall meetings.
Yeah.
Going to them.
Yep, the Dallas and Hood River and Central Oregon too.
Fantastic.
Since we're talking about Walden, I heard an interview with him where he talked about that it was impossible for an insurer who wanted to send out correspondence via email versus letter, and that was prohibited under the Affordable Care Act. Isn't that granular? I mean, he was saying there's no reason that there shouldn't be.
I feel like I saw one small thing in the proposed reg that, no, in fact, it's actually about SHOP, and it was about that everything should go via email, but if the employer really wanted it via mail, that you could mail it to them, but you also had to email it to them. So I think everything is subject to how the enrollee wants to receive it. So if they want a paper copy, you're supposed to send them a paper copy, but if they want an electronic copy, you're supposed to send
It didn't make any sense to me, and I thought surely it can't be that, but he brought it up in the
I've
interview
heard that
with.
from OHA, that like some documents at OHA can't be emailed, they have to be hard mailed due to privacy rules.
And maybe that's what
Yeah,
he was
I hadn't
referring to.
referred back to the ACA, but just HIPAA rules.
Yeah,
So,
That would capture
Yeah.
part of ACA.
But that would have been he was talking about changes, this
Yeah,
change,
that's a
this
HIPAA.
recall and,
Right.
or repeal and replace, and that was one of the things. So,
I mean, just to sort of tie the knot on our conversation from earlier, it does seem like if these estimates of the tax credit eligible population are to be believed, that we are not doing a very good job reaching the African American, American Indian, Alaska Native, and Hispanic Latino population.
Yeah, thank you. We caught that as well. Yeah, that's part. Particularly the African American number, not to ignore the American Indian number either, but yeah, that one really stuck out to us as well as not sure yet. We've kind of looked at that. We have some thoughts, but it's something we want to take a look at going forward for sure.
One driver on the American Indian population is that many of the people in those communities can get care through the Indian clinics and the Indian Services clinics without having coverage. And but I think we can think of some ways to better reach and market to them, even if just using the message that it's better for your local clinic if you have coverage. You can help them that way.
You also get amazing benefits out of the ACA. There's no deductibles or cost sharing on many of their plans. They can switch plans every month. They can enroll at any
I think
time.
that's just under 300% that they have noted on.
Correct.
Right.
Yeah.
Well, we can start that message in June when we meet.
Oh, yeah.
So it seems like they should have taken it up at a greater rate despite having access to services.
Yeah.
just one more quick question. So under other and multiracial, that's fairly high. Is there some, in terms of percent the penetration, is there some chance that some of the Hispanic Latino population may have identified with other as opposed to Hispanic Latino?
Exactly.
So that's a lower figure.
Before I hand it over to Elizabeth, just real quick, want to make sure. So we're going to do a little bit of follow-up on the attrition rate, 2016 to where we started this year. The meta level percentages this year versus last year, percentage that use an sister, and then maybe a little bit follow up on the Hispanic, Latino, the ethnicity versus the race piece.
And I also have plan selection comparisons between 16 and 17, and how many use the sisters.
Yes. Yeah.
And if you have any more questions, if you mind emailing me, I'm sure we'll send it out in our follow-up.
So in my marketing overview, I want to tell you about some of the marketing efforts that help yield those numbers. And when I say marketing, I am focusing primarily on advertising. So really the mass media messaging as opposed to some of the person-to-person on the ground outreach is noted, but is not the focus. This is mostly advertising. So there were three major, I have this. There were three major objectives for the marketing plan for 2017. One was to drive enrollment, especially for subsidy eligible, to encourage returning customers to actively shop instead of auto re-enroll. The reasoning behind that is that they are more likely to end up in a product that truly fits their needs and their budget, and therefore more likely to effectuate. If they've chosen something instead of been auto re-enrolled in something whose premium perhaps changed over from the previous year.
Can I interrupt you on that point just to talk about something that's a little bit of a tangent, but that reminds me, and I think it's important for us to think about. About a month ago, we had a conversation with one of the carriers that became concerned that it was seeing abnormally high cancellations, and we sort of worried about where we saying, call it a Trump effect of people thinking the mandate was gone and canceling their insurance. Turns out that wasn't happening, but what does appear to be happening, and it really matters when you think about the shortened open enrollment period this year, this next fall, were cancellations offset by signing up somewhere else, and so it was the people who got their first, who hadn't paid attention to anything, who hadn't listened to that message about go shop because you'll be happier, got their first bill and said, what the heck? And it was still open enrollment, so they went and shopped. That was what caused them to shop and pick another plan. They're not going to have that opportunity this year. They're going to get that first bill and they're going to say, what the heck, and they're going to be stuck.
And there's no sticker shock special enrollment period.
Right, exactly. And so we should probably expect that there's a percentage of them that are going to just drop their coverage.
Yeah. I'm going to make a note of that for messaging.
We're definitely going to wait for people coming in January as well, just used to re-enrolling in January.
Right.
The procrastinators have been doing that.
Right.
Yeah. And the third one is to build trust with customers and stakeholders. And just some very high-level outcomes that pair with those objectives is that, yes, we did enroll a large number, and it was a 5.6% increase over 2016. I think Michael called it 6. I should round up as well. 6% increase over 2016. This is also the largest increase among all of the marketplaces that have our format, which is the state-based marketplaces using the federal platform, or the highest increase of any of them. 77% of re-enrollees actively shopped. Now this differs a little bit from what you'll see in Michael's numbers of what percent actively shopped, but that's because his number is out of all enrollees, and mine's using a little bit different denominator. It's active shoppers out of all re-enrollees. So because that was our objective, I chose those denominators. So that's a very high percentage who did what we recommended they do. And 38% of enrollees turned to Marketplace Certified Assisters. And this is even though only 32% of all enrollees were brand new customers. So what this is saying to me is that they are, number one, trusting our advice to go talk to someone that we have on the ground whom we've certified, but also they're finding value in that assistance even when they're returnees.
And that's the answer to the question Sean asked earlier, right?
Yes, it is. It's 38% received. And those assisters include agents.
I have a question on that. Now, do you have a benchmark? Do you have a percent that you would like to see using assisters to do their?
You know, it's hard to say because we don't have a number from last year. This is a new data point collected by CMS. I mean, I don't know what to say because I want everybody to use an assister, but I know the capacity is not there for everybody to do it. So, and to some extent, I am open to the idea that a higher need for assistance could be a greater complexity of the online system. And so, you know, I still firmly believe this is a net positive to have more people going to assisters.
Do we have any data on satisfaction with your plan based on whether you used an assister or not?
That, I haven't seen anything like that, but I've been here 4 months.
We would be really interested to hear that for grant writing in the future.
Well, I'm thinking as we do focus group or surveying work, that might be interesting data to try to capture. But I think we did ask if they used an assister.
Yes.
So we would be able to add a question about satisfaction or cross-tab it.
Yeah, that would be great to know. Yeah.
I don't think we asked, are you happy with your plan?
Yes, if you were having a question
or the process, maybe.
Right. So to firmly answer your question, I don't know what is the number we'd be shooting for. Here is the kind of timeline and what were the key activities in the environment as we approached open enrollment. Began November 1st. The deadline for January 1st coverage was in the middle of December. The president was inaugurated on January 20th, and that same day he signed an ACA-related executive order that gave the impression, we're still not totally clear on how true it is, that the penalty would not be enforced. And then a week after that, healthcare.gov scaled back their advertising. tried to pull down everything, but wasn't able to completely, so we call it a scale back. That was the point at which the marketplace then widened our advertising, which I'll get into in a future slide. And then 4 days later, January 31st, open enrollment ended. Here's what we did for marketing. Our primary advertising in English was online with digital ads. We had display ads or still ads. When I say still, I just mean something that's not moving, that were on websites, including Facebook, and ads on video ads that played on online services, Hulu, Pandora, and YouTube. We had radio ads in Russian and Spanish language stations. We had newspaper ads also in Spanish and Russian language publications, and also in English in regional publications, and those were co-marketed, co-branded with storefront agents. So it was not only a, get insurance for the marketplace, but a very concrete, specific where you could go and get assistance to enroll. In those final days, when the healthcare.gov ads came down, really very much thanks to Barry and Pat's leadership, moved very fast to get the dollars to widen our ad buy. And we increased our digital advertising, and what that meant was that the online ads that we had would show up both more frequently and in wider geographic areas. There had been some priority counties where we did more advertising during the year, and there were a lot of counties. So it was not a narrow group, but once we knew that the healthcare.gov ads were coming down nationwide, we also expanded the digital buys in geographic areas as well. So we were statewide with the same frequency for those last 4 days.
We pumped the budget by what, about 100,000?
It was like 170. Yeah, yeah. And in addition to those advertising activities, we also did a lot of earned media. So earned media is news stories and news coverage based on pitching. A lot of that was around the different deadline days, the deadlines for the next month, like the January 1 coverage and such. And lots of in-the-field outreach and sponsorship events. So our outreach team, who's not part of the marketing team, but they really do end up serving a very symbiotic function there, go to different community events like a walk for heart health or rodeos or community festivals and table with information. And so they supported the broader marketing. Agent storefront outreach is obviously a huge messaging channel, and then they funded community partners. Now the agents and the community partners primarily provide the one-on-one assistance, but there is also a substantial portion of their work that has to do with getting the message out. And so we consider that support of marketing. So that is that sums up 2017, and as you know from some of my reactions to some of the data here, we're already looking ahead to what the 2018 open enrollment period will be like. It'll have some new challenges, but we've got some best practices and lessons learned from these previous years, and so we're going to do everything we can to keep the enrollments up. Any questions?
Anyone?
I have a question, just to go back to the data around Asian Pacific Islander. Is there, does the marketplace break down the Asian Pacific Islander category, or is it just API? Because that's often been a point of contention with data, because it really skews the situation with
Pacific Islanders. Also, Pacific Islanders are not just COPA. It's a whole, a group of Pacific Islanders that are not the COPA country. Even they may say they're Micronesian, but they're not necessarily from COPA countries. One other question is, how is it determined who is eligible for the marketplace?
So two answers. I'll take the first one first. So basically, we're showing you what we get.
Okay.
Yeah. This isn't edited. I'm compiling the stats and the demographics as CMS captures it. So I can give you their definitions. It's basically, these are the categories they offer.
It's census categories.
Yeah. The second piece on UI, so it's kind of beyond. Essentially, what they do is they take different databases to estimate salary levels, household sizes, composition, extrapolate that out to tax credit eligibility. They use a variety of different data sources. So census data is a big piece of it. I wish I could speak better to this question, but essentially publicly available sort of demographic warehouses and databases, and they try to specify that and make some assumptions for Oregon, and project out, here's how many people we think should be in the state.
Yeah, because even, I mean, when the bill was created, Oregon basically does not have any data that's Pacific Islander specific. And that's kind of the field where I work in data on Pacific Islanders. And really, there is no reliable data on Pacific Islanders. And so it would be very helpful if, doing the COPA enrollment to really, break down that data.
And we do have that feedback.
Yeah, exactly. But also to cross-reference that with the bigger Asian Pacific Islander, because then, you could really separate out and know exactly, how much the penetration is within Pacific Islander community and how much penetration is in the Asian category. And when the bill was written for the COPA Premium Assistance Program, that was the issue. We were trying to really come up with a number that was big enough to justify the bill, but also keep it low enough to make it a little bit more politically palatable for the legislature. So it really,
with no data source,
exactly,
pretty much
exactly.
Whatever you need.
Right, but anecdotally, from some of the data that we do, the numbers, pretty huge, bigger than, one of the reports that comes out and gets cited for Asian Pacific Islander communities, they put Pacific Islanders as the total population within Oregon as around 3,000, which, that's the discrepancy there is just huge, because only one small community within the Pacific Islander community would, totally be like 5,000. That's not the total for the state.
Right.
So,
you're looking at, I think you're on the second page looking at that 10,000.
Right, right.
Asian Pacific Islander.
Right, and that 10,000 to the Asian Pacific Islander, that's, just looking at the numbers at face value, that's, so.
I'm happy to kind of take that back and see if we can get just folks, Urban Institute, and see what, break that out a little more and see what they say.
Yeah.
Yeah.
All right, well, we should probably move on because we got a little bit behind schedule, but I think that was all really good information. So now it's time to hear from Anthony again about the CMS auto-enrollment rule. This is maybe a somewhat obscure topic to many of us, but pretty important.
So CMS has a rule that basically says that if a consumer loses an insurer, the consumer's insurer stops offering plans or stops offering plans under a specific product that a consumer had, then they're going to auto-enroll that consumer into another carrier or another plan. We had discussions with him for this this plan year 2017 about about this rule and about their about them putting our consumers into other plans. And the agreement was that we, the marketplace, would crosswalk our consumers who lost plans, basically because insurers had pulled out, and basically talking about the co-op and
LifeWise.
and LifeWise. Yeah, thank you. So we would crosswalk those consumers, and CMS would not do any crosswalking. So unfortunately, they didn't really abide by that agreement, and they ended up crosswalking a number of consumers into other plans, and this confused the consumers who had actually gone and shopped. This confused their agents, it confused us, it confused the carriers. Everyone but CMS was confused.
Well, they were confused too because they did it wrong.
Oh, well, that's true. And they didn't.
They may not have known they were confused.
They didn't talk to us about it at all. So one of the exceptions to the CMS rule that they will crosswalk is that if the state has a law that basically prevents CMS from crosswalking, then they won't do any crosswalking. So that's what this Oregon rule is about. That's why we drafted it. Real basic, the rule allows the director to determine whether or not a consumer should be crosswalked, and if so, then it gives the director the sole authority to crosswalk the consumer. So the idea is to put this rule in place to prevent CMS from doing what they did before, and it's our position that the marketplace, or the director specifically using the marketplace, is in the best position to determine which, if crosswalking is necessary, to determine which plans consumers should be crosswalked into. And one of, I guess an example of that is when we lost, a significant number of consumers due to co-op. Well, actually, the carriers that we just talked about pulling out, that ended up being a significant number of consumers. And one of the concerns was we didn't want all these consumers going to one carrier, given the instability of the market, and this one carrier assuming all the risks. So Katie did a masterful job of sort of determining where consumers could go to kind of spread the orphan consumers among the different carriers, so that one carrier wasn't receiving all of this risk at once. So that's why we're proposing the rule. I think we'd like to use you as our advisory committee. I think that was the plan. I think maybe maybe a little bit got lost in the shuffle. But there are some other documents that were as part of rulemaking that we'll need you to look at, but I think we'll send those out via email. It shouldn't take you very long to consider those.
So really, Anthony, if I'm hearing you correctly, I understand this rule. It protects the consumers from being erroneously crosswalked, because what we want them to do is to shop for themselves. They are the best deciders of their health insurance. If that shouldn't happen, the next best person will be the director. Does this allow the flexibility?
Well, that's stated a little weirdly, but
okay.
I think this lets us control when and how and by whom crosswalking happens. In the absence of this, CMS controls that, is the way I would.
Right, and we have, the current regs allow us to decide first if we want to crosswalk people, and then if we say no, then CMS will do it, which is what happened the last time. CMS told us that we said we would crosswalk the 4 carriers that were exiting completely, and they said that they wouldn't look too closely at the other carriers' crosswalks, but then they did look at Moda's crosswalk and noticed that they pulled out some service areas, and so then they just went ahead and did the crosswalk for those consumers. And so
this rule lets us really have control. So like if we only had one carrier in one area, then it would make sense to crosswalk anybody who had been in that area to that one carrier because it's administratively easier for them. And so in that case, we might choose to do it. But if it's in the metro area where there's a whole bunch of carriers and a whole bunch of plans, it doesn't make as much sense. But we don't want CMS to make that decision for people either. So this rule really puts the whole responsibility for crosswalking or not crosswalking on us and prevents CMS from doing it at all.
So there's like some flexibility to you guys to defer back to CMS if due to budget constraints.
We would still do it ourselves. We would never let CMS do it because they, like with the motive people, they didn't crosswalk people like they're in a standard plan. They didn't crosswalk them to the standard plan. Like, I would have done that. So we would never defer that to CMS anyway. But this just allows us to either do it or not do it, whatever is best for Oregonians. Versus under current law, we have to do it or CMS will do it.
If you just got a question.
Having, I think crosswalk, I mean, I've never heard that term before. I think what Chidi said, it is more, getting people to shop is very, very different than having the director choose.
This is if they don't shop.
Yes, I think so. They always will have the option to shop.
Right.
So, in my case, Lifewise pulled out, and I received a letter from Health, the federal marketplace, I guess, that said, you know, we picked a plan. Your carriers left the market, so we picked a plan for you. Actually, that was quite convenient.
Well, good. I'm glad to hear that because I chose that plan for you. So yay.
And it was totally HSA plan out there. I mean, I'm not sure that's what I was told, but so I guess what I'm hearing happened. Did the Oregon marketplace send you that letter, or did the federal marketplace?
Healthcare.gov sent you that letter. I sent them a document that said, here are all the Lifewise plans. Here's where they go. And so they did that because this is where like the weirdness gets into like the things that we control as a state-based marketplace versus the things they control. So they won't give us anyone's information, so we couldn't send anything out. So they sent things out to consumers.
Okay.
And then the carriers themselves would have also, like Lifewise would have sent you a letter that said we're leaving the marketplace.
Right.
But they wouldn't have known where you were going.
Right.
So, and one of the areas that we heard a lot of confusion in for people was that they didn't pay attention to the things that Healthcare.gov sent them. And so then they were enrolled and they were like, why is Bridgespan sending me a letter? Like, what are you talking about? And they were really confused. And then we also had a lot of people who had a hard time that they actually chose to go direct and just buy their own plan if they were aging off into Medicare or whatever. And they're like, why is this company sending me a bill? I don't want their plan. And so there's a lot of things that we felt weren't the best for consumers.
Right. So and what I'm having a hard time is, so what improved? So for me, the biggest difficulty was Oregon didn't seem to know what the federal was doing and the health insurance. I mean, I received calls every day after I had enrolled, paid a premium. So I don't understand what improved.
That's a somewhat different issue. What improves is we make the choices, not healthcare.gov, and we think we're better than they are.
But you did already.
Well, no, in your case we did. There were cases where we didn't, motive being the main one, where despite the fact that we thought we had an agreement that they wouldn't do it, they went and did it anyway. This arguably will preclude them from doing that.
So what this allowed is what happened.
This should ensure that everyone has the experience that you had.
Or it may be that, and if it's only one carrier leaving and you live in the metro area where there's a lot of choices, we may decide that as a consumer, you are better equipped to make that choice versus us making that choice for you.
Yeah, I will just, it was nice having somebody have made it, and I went and shopped anyway. Ended up staying with the plan just because it was HSA. But I knew that it had been done, that I was already, I just needed to pay the premium. So
but also this year with the expanded open enrollment, then you would have had that time. But with the compressed open enrollment, you're not going to have that time. And it'll be, hi, I chose this plan for you, go, versus.
Which might be good.
Exactly. There are pros and cons, which is why I asked Anthony to write the rules to just be like, we're not doing it ever again. And Anthony is a lot smarter than me on that and said, let's keep it open in case we want to do it. So this allows us to really make decisions
versus like, well, we're going to do it because we don't want CMS to do it?
Well, I guess then I would encourage that. Some people won't shop. I mean, it's a frustrating experience, so make a choice.
Yeah, that's great feedback.
So, this is a rule. I'm assuming that the assumption underlying this is that you have the statutory authority to do this already. Is that, I guess I'm not sure. I don't necessarily need to get into all of the details about what gives you the statutory authority to do this, but I'm a little bit curious because I can't remember. I mean, it seems like a big enough issue that it could be something the legislature would debate.
Well, we have a statute that requires the marketplace to assist individuals to enroll in qualified health plans, and that's where we think our authority to draft this rule comes.
We also have broad authority to take actions necessary to ensure the stability of the market, which I would argue this probably could speak to as well. I think it's, again, the really dull superpowers.
And then, what is it that prevents CMS from just asserting their authority to do this anyway?
So in their regulation, their regulation is basically says to the extent allowed by state law.
Okay. But from a practical standpoint, the answer is nothing.
Right. And I mean,
assert versus actually do, I suppose, is a distinction.
I guess it seems somewhat unlikely that the current administration would want to overrule the existing rule so that they could push more.
Yes, the federal could do more.
So the federal government could do more to enroll people in ACA plans, but I don't know.
And is rural the same as law?
An administrative rule does, yeah,
They
it's considered a law, yeah.
Anthony, next step?
So the next steps will be for us to send out the additional documents. I think it's the statement of need and fiscal impact. We'll have instructions for you what you need to look at. We'll just ask for your feedback. If you don't have any, that's fine. That's been involved in many rulemakings, and very rarely do people have anything to say about the document, which is totally fine.
Do we have a time constraint on adopting this rule?
We don't, because it's for next.
Before open enrollment starts?
Yeah, okay, so, and I presume that the part of the documents would be like a fiscal statement and that kind of thing, right?
Yeah, so the statement of need and fiscal impact will.
Yeah, so just from a form of action standpoint, I think what I would prefer is if they got all the materials and then this reappeared as an action item on their next agenda, and they actually took a vote on a recommendation of support or not, whatever, whatever.
This time I'm gonna let Pat have his way.
I have to send Anthony an org chart about once a year. It's about time, I guess. It's a year, right? Not
I can't believe I'm about to say this, but I would actually be a little uncomfortable with us voting on something like this without having either of our health insurer representatives here. But it seems like their perspective on this is important.
Always looking out for
So we'll bring this back next time. We'll send the documents and then we'll take a vote.
Great.
And the next time, right now it's tentatively set for June 8th, 8:31 in Klamath Falls. We are still working on finding a location that would accommodate a group size, and you will get the information to us as soon as you can, because I know we have to arrange for travel and whatnot.
My mother-in-law lives in Klamath Falls. I can see if we can use her house.
Well, this should be nice. We could probably do it outdoors.
Yeah.
Camping trip.
It would seem like OIT would be probably a pretty good bet.
I think we're trying to find space in one of the reservations.
High school gym floor, right?
But that's our first priority, is finding space in one of the reservations. And we'll check out OAT, and then last report will be Anthony's mother-in-law. I'm sure he was like,
All right, well, we should at least theoretically open up for public comment. I don't know if anybody's joined us on the phone or if anybody here would like to provide some public comment.
Yeah, I have a few things. All right. I'm Joel Bogum with Century Benefits Agency in Portland.
Come up to the table if you like.
So a few comments, I guess. So on the auto enrollments, what we found is most consumers, I mean, they're not going to open any mail from the marketplace.
They get so much of it.
They get so much of it, they're overwhelmed, and they're just going to put it in a pile and not open it. So anything that could be done potentially to like have a automated phone call, or somehow getting text messages or emails or something from either the carrier or the state of Oregon would have a lot higher response, so that they would actually go out and complete their own shopping experience, so the state doesn't have to deal with it. So that's in that situation. Just from our numbers, I'm kind of curious if you guys have data on this. Is before December 15th, approximately 65% of our enrollees are silver plans. After December 15th, they're 65% bronze. So I think a lot of the reason for that is really just comes down to people who need to use their insurance are going to make sure it's taken care of. And you guys alluded to this already, but I'm just kind of curious if you guys have any data on that. I know we have the 60% total for all of open enrollment, but if we're looking at shortening that time frame to only 6 weeks, 7 weeks, this upcoming open enrollment, then what does that look like? Where all the bronze people, what are they doing? Are they going uninsured? Are they, there's a, I don't know if you have any data on that, but
They don't give us plan level by week. So we basically get just an aggregate enrollment total on a weekly basis with some limited demographics, but the plan level piece only comes in. That's a separate cut, and they only gave that to us halfway through this year and right at the end.
but is that something that we could have access to?
We used to get that from DFR. We used to get
Yeah, that's a good point.
that.
The open enrollment, it might be in there's a weekly open enrollment report that carries through. Yeah.
And I don't know if they're still doing that, or.
I think it was just till the end of open enrollment.
I mean, I'm sorry. This year, did they do it this year?
I don't think they, no.
Oh, they didn't do it? Oh.
Yeah, I think it might have ended.
We'll follow up though. Thank you. That's helpful.
We'd love to have your
Thought,
contact
that's it.
information after.
Just piggybacking on that a little bit, do we have information similar to that about special enrollment period enrollees? Just in general, I'd like to have some more information about who's signing up through SEPs.
I think it's still a little too early to get that data. How long ago did we get the open enrollment data? It's already April.
But we might be able to get it for like 15 or something like that.
Yeah. We may have some ways we can get that or approach that.
I've never actually seen anything about special enrollment generally, like how many people a year sign up in special enrollment, what do they pick, what's their demographic, or anything like that.
It's not that granular. It's always just like how many people enroll during SEP. But I think under the new SEP rules, at least when it was like, there was supposed to be like a pilot and they were just going to like choose people, I think there's supposed to be some information that was going to come out of that. So maybe we'll actually get something now that they're going to just make everybody go through the crazy SEP process.
One of the things in that comment period was whether or not they should leave a small subset of the population outside of that thing. That way they can finish the studies. I'm not sure whether they've decided one way or another on that yet. So
They haven't finalized that right yet. We'll have to look at it when it comes out.
This is a very interactive public comment period.
But again,
we're all public.
lively. The last thing I have is just, I guess, kind of on pricing. And what we saw this year, a lot of people, as the prices are, the premiums are continually increasing, they're shopping more and more on price. So like in the Portland metro area, you see a lot of people, we talked to a lot of people that say, well, what's, my premium's going to what? Okay, well, what's less expensive? What's the cheapest thing you have? And then it's a Kaiser, generally, in the Portland metro. And now you're talking about just kind of a shift in client or consumers going from, like, say, a Providence or Legacy or OHSU or clinic to Kaiser, and then whatever happens this year in the rates, if that switches back, now you have people just jumping back and forth between not only health plans, but you have it within the whole system of the healthcare system. So I think it creates a lot of more expense when they're onboarding people to a clinic or hospitals. So anything that can, I guess, keep the bottom level prices similar.
Yeah, we talked about that early on, that we're trying to narrow the range of prices so that you don't find yourself $50 low as a carrier, and congratulations, here's your 70,000 new customers.
Yep.
Can I just ask a follow-up to that? So you're saying that the customers mostly shop by price, the Portland area. Does the size of the network?
Bronze.
Does the size of the network matter to them?
Not usually.
Not usually.
No, the price shoppers, if they see the value in a network or a plan, then they're willing to pay more for it.
Okay.
Although I can add just a little bit to that, Joel, and that is, we want to make sure that their doctor is in whatever plan they choose. So I always make sure that if they're looking at, if they're price shopping, that their doctor is also in that plan.
Yeah, I guess kind of building on what I was saying is, a lot of them are just, they'll say, yeah, I've been with this doctor, I saw him 2 or 3 times, or maybe I saw him for 10 years, and they're still saying, okay, well, for $30 a month, I only go once a year, and
not worth it.
I don't know my doctor's kid's name, so I switch.
Yeah.
A question for you and the other agents here. If there were kind of more simplified, standardized information available about networks in the way that there's a CMS pilot to do in some states that would have kind of like a 3 or 4 tier network size descriptor that went along with each plan. Do you think that would be meaningful for consumers or not? We decided not to do it in Oregon because CMS's method doesn't work with Kaiser. It completely blows up their method of counting the size of the network. But do you think that would be useful information for people?
Updated. I mean, I guess the biggest issue is like that information is not accurate. So it seems like it's great. It gives a false sense of.
And does it include people who are taking new patients is one of the big ones? Because even if you get CCOs have pretty good data on who's taking that, but not who's actually accepting patients, and so there's that follow through to access. So
I'd be happy with the carrier tools for network to be accurate.
Yeah.
Right.
Yeah.
Exactly. The search.
Yeah, I would say 3 or 4 years ago, yes, where it's mostly PPOs out there. That would be very helpful. But now there's so many differences with the PPO, HMO, POS. You got to have a primary care, CCOs. It's so confusing that the consumers are already confused and just saying, this one's a 1, this one's a 3. Their primary care doctor might not be in that network, and they think it's a big network because it's a 1. It would be confusing, I think.
Some years back. Yeah.
Maybe.
Yeah. It stopped, I think, because it was too confusing.
All right. Anything else?
No, that's it.
Thank you.
Thank you so much. Is there anybody on the phone who would like to talk?
We should have a moment, because that was our first ever public comment.
And he's from Portland and drove to Eugene to get it.
Okay. All right. Well, does anybody have anything else for the good of the order?
I have a question of the brokers, actually. And this, I've raised this before, but do you run into any issues when, somebody's shopping for the least expensive plan, or as they found out, the least expensive plan, but when they go to get care, their negotiated rate of their insurer is more than they thought it could be, and other insurers would have lower negotiated fees. Do you ever see that?
I don't think I've ever had a consumer that would get that detailed on.
That would know.
No.
What about you, Joel?
No, they wouldn't know what the other insurers negotiated rate was.
They wouldn't look that up, yeah.
Okay.
Generally.
For me as a customer, that is a huge miss, because that's really what I pay, is that negotiation. So my insurer choice would depend on that, but it's information
You can't.
I don't have. I can't get it from a provider, and I can't get it from the insurer.
Just snapshots of the OHA report that showed the different, you know, it was some, but not as detailed as what you need to make.
That's why we need good price transparency too.
Right. That's why I bring it up. You know, I think if there are things that we can do, by rule or otherwise, that would be good. Which takes me to another comment. So at our next meeting, so rate filings will have been. So will we have a big?
Possibly. We may change the time. When's the next meeting? Oh, June. Oh, yeah. No, that'll happen. Yeah. We may shift the timeline a little bit, but not more than a month.
Okay, for the rate filing.
Yeah.
And so will we have kind of an in-depth look at that process and the filings, or is that beyond the scope of?
I feel like an overview of where things are at would probably be a good idea.
A process overview is easy.
Right.
If we've shifted the timeline toward the end of June, that will be too soon for a comprehensive look at what came in on rate filings. A thumbnail look would be easy. We could do something comprehensive. Actually, what would make more sense for comprehensive would probably be not as filed, but as approved, which would be later in the process. And so end of the year meeting would give you, I think, more useful information.
We can also kind of see where things are at, because there might be some big headline takeaways that we'll want to talk about. If there are, you know, huge increases or not, either of those would be.
I'm hoping the big huge headline is stable rates.
Or if there's a big if there's, you know, companies pulling out of markets or parts of.
I'm hoping the headline is companies stay where they are. Rates are about the same.
Or, you know,
let's send out the right
vibes.
A very boring vibe.
Those superpowers needed to be used.
Yeah, so I am guessing that we're going to have no lack of items to talk about at our June meeting, but one thing I just wanted to flag is it seems like it is possible that there will be some set of developments between now and our next meeting that could include federal developments or state legislative developments that might necessitate us talking again between now and then. So we can kind of play it by ear, but we might want to call an emergency conference call or something like that. So just keep your eyes out. And you know, if anyone sees anything that you really want to talk about between now and then, feel free to call me at any point. But I think there's a real chance that we'll need to talk between now and the next meeting.
You've got Trump's wires tapped.
Yes.
He was right about the name starting with O. Or something. I just said that on the record.
Thank you.
All right. Thanks, everyone. We are adjourned.